आप तैयार है? Ready? Huh? Not you, sorry. Okay. Someone else handling the slides? Okay. I think Ravi will. All right. Good morning, everyone. Welcome to the second day of the Royal Society INSA convening. This morning we have two couple of interesting sessions, but the first session is going to be on screening programs and early detection. And we'll start off with Dr. Ravi Kannan, who's the director of the Kachar Cancer Hospital in Assam. And for those of you who have not been there, I strongly recommend that this time or next time when you have some time in India, you travel to Assam. It's a very beautiful part of the country. And Ravi's done some amazing work there, particularly on community-based screening. So over to you, Ravi.
Thank you. Thank you very much for this opportunity. अरे ये क्या आ गया? Sorry, कुछ और. Sorry, ma'am. There's a goof up. Yes.
Yes, so for yesterday we ended up concluding with the big questions about how what climate change is going to do and where we're going from there. So we will have an extra time slot today free because Rani Kanti is not joining us. So there'll be plenty of time for discussion in the afternoon so that we can tie things together. Over to you.
Okay. So, I work in the northeastern state of Assam, in the southern part of the state, and the southern part of the state has those three districts, and the hill district of Dima Hasao. And just to set the context, and we see I work for a not-for-profit hospital. We see about 5,000 new patients and about 30,000 patients on follow-up, and their economic profile, most of them are daily wage earners, and there are issues of access and affordability and things like that. Now what happened in the early years is a majority of our patients would not accept treatment. Almost 75% of patients would default treatment and go away home. And it took us several measures to change this. One of the most important measures was getting engaged with the community. And if you look over the years, the trend has changed. Most patients accept and complete prescribed treatment. Same way in the beginning years, this is data from breast cancer, but this is so for oral cancer, for rectal cancer, cervical cancer, all. And most patients would come with very advanced disease, and over the years there is a very gradual shift towards earlier stages of disease. Not very remarkable, but we don't see as many stage 4 cancers as we used to see earlier. In the early years, our standard thing was, this was not actually done with the idea of promoting early diagnosis. We were out into building relationships with the community, and 2007 to 2014 we would have done more than 700 odd. Every weekend we would be out in the community. And then what emerged at some point of time was, there is no documentation. I don't know what impact we had on the community, and so as an exercise to promote early detection, this was probably a futile activity. But what it did do, it built the hospital's reputation. We were able to build friendships in the community. The hospital earned a reputation of being a pro-poor hospital, and now we have a lot of community support. Wherever we go, there is community support for our activities. And these camps also helped us understand the topography of the area and the needs the community had. So starting 2017, when Dr. Soumya was the director of DG of the ICMR, we started with a community-based program for early detection of oral breast cervical cancer and diabetes and hypertension. And this program was supported by the ICMR. We worked with the NICPR, the Tata Trust, and the National Health Mission. And we chose one health block in Kachar district, which is one of the districts in the Barak Valley. Had a population of about 2 lakhs, screen eligible population of 66,000. And what we did was we trained ASHA, accredited social health activists. For those of you who don't know, in 2004 we created a community-based health worker system who are incentivized, primarily aimed at reducing maternal and infant mortality. But now, and they were called ASHA. ASHA in Hindi means hope. It's an acronym for Accredited Social Health Activists. These are women who hail from their villages, and each ASHA is responsible for a population of about 1,000. And she is a community mobilizer to bring pregnant women for antenatal checkups, to bring women to the hospital for delivery, to ensure that the newborns are immunized on time. And then their roles have slowly expanded to immunizing kids, for sanitation activities, for several activities. And so we trained ASHA to go door to door and triage examine the population for oral, breast and cervical cancer. We had to have ethics committee, we had several objections, but then we went ahead and did that. And the ASHA were taught to examine the oral cavity, palpate the breast and do a visual inspection of the cervix with acetic acid. And all they were taught to do was identify what is normal and what is abnormal. They were not taught to diagnose erosions and ectropions and cancer and all that. They will just look at the mouth. Mouth looks normal, mouth looks abnormal. Palpate the breast, breast feels normal, breast feels abnormal. And then they were taught to record one blood pressure reading and do one capillary blood glucose measurement. The equipment was provided by Tata Trust. When we started this, we had to answer 4 questions. Would the ASHA be willing to participate in an activity like this? Would the ASHA be capable of doing this? Would the community accept the ASHA in this role? And is a screening activity like this actually possible in the homes of the population? By the time we finished, we were able to answer. What we did is we got all the ASHA. We did several rounds of raising your hands in ASHA meetings, and most of, because this was an incentivized activity, the ASHA are not paid a salary. They are incentivized for every program activity that they undertake. And so when we asked them, every ASHA was willing to do that. Then the question was, the ASHA had too many jobs to do, will they have the time to do? So we actually did a time motion study for the ASHA, calculating 5 hours a day for 20 working days. And we found that they were engaged for about 12 or 13 days in a month, and they still had 7-8 days that was available, 7-8 days worth of time that was available for them to do an activity like this. And then ICMR helped us write out a mobile application to have a digital entry. And so at that time, we actually wrote out a triage questionnaire, questioning them about their tobacco habits, about alcohol, about a whole lot of symptoms. And then because many of the ASHA were not capable of reading and writing, we had pictorial representations for them to identify what looked abnormal. And then we trained master trainers recruited for this purpose, doctors, nurses, who then went out into the community and trained the ASHA. The ASHA training had a theory module, then had a practical module, and then there was a communication module. And in the and they were taught what to answer, what not to answer, what questions they should say, I don't know, I will find out and come back and tell you. And so, and then at the end of it, we actually conducted an examination for the ASHA, and we trained more than 90% of the ASHA in that health block, and the scores were pretty good. The good thing is, 3 years after the project was over, in another context, when we went back and tested the retention of the ASHA, pretty good. All of them retained what was taught to them. And so then we created a referral pathway. The ASHA were trained, and then the ASHA went out in the community. Initially, we would go with the ASHA on their home visits, teach them how to talk, how to screen, and then we would go with them and watch them do it. And then anybody they thought was abnormal was then referred to a sub-center, where they were then screened by a medical officer. So at the end of the project, what happened was we reached out to about 47 or 48,000 people, out of whom more than 95% of the population, there was an informed consent process. More than 95% of the population agreed to participate. And out of the 46,000 odd people who participated, about this comes out in every subsequent program that we did, about 10% of the population turned out to have an abnormality. So when we asked them to come to the 10% as seen by the ASHA, when we asked them to come to a sub-center, about 80% of them reported to the sub-center. In the sub-center, when a master trainer examined them, about a third of them were then asked to come to the hospital. And when we asked them to come to the hospital, 50% of them drop out. They don't come for examination. This is in a programmatic mode where we are literally in the field. So sometimes we wonder, what will happen if it is in a service mode in the government. And so, but anyway, at the end of it, for 46,000 people, we identified 55 cancers and 200 people with pre-cancers, mostly oral cavity. We also had a system built in where we said we will examine 10% of the population that the ASHA said has no problem, to make sure we are not missing out something. And we couldn't do 10%, we did about 5%, 4.5%. And then the good thing is, almost always when the ASHA said no abnormality, there was no abnormality. When the ASHA said there was an abnormality, several of them turned out to be without any abnormality. But there was no overdiagnosis because we were not screening for cancer. We were just looking for some abnormality in them. So there was no overdiagnosis bias. The other good thing that happened was, after the project ended also, subsequently people from the block continued to come to the hospital for evaluation, and about 40-50 of them were diagnosed with cancer following the end of the project. In between, we also got funding for hybrid capture, for testing for HPV. And then before COVID came, we had a plan that we would do 50% as a health worker drawn sample and 50% as a self sample provided by the woman. And by the time COVID came, we had to abandon the idea and we had to convert everything to self sampling. But whatever little data we have shows that self provided samples and health worker drawn samples have similar outcomes. The other striking thing that came out through this program was, while we detected 55 cancers, we detected 3,000 people with diabetes and or hypertension. We asked them to report to the district hospital and the primary health center for treatment. We do not have the data on what happened to them after that. But then we realized that for the ASHA to go home to home and screen people is a lot of effort, especially cervical cancer. We have to educate the woman, we have to convince the woman, we have to take consent. She has to lie down in a lithotomy position, we have to give her a private place in the house. It takes a lot of time. Each cervical cancer examination takes at least 40-45 minutes. And so we changed the whole cervical cancer examination strategy to HPV testing. And only women who test positive for HPV are then screened. And typically in all the districts, we found that the percentage of HPV positivity comes to about 6-7%. So what we said is, in another district, in another health block, we said, instead of doing door-to-door examination, what happens if the ASHA goes door to door and creates a blitzkrieg of information? So we designed flip charts, we designed pamphlets, and we said the awareness should promote self-referral. People will go through the warning signs, people will fill up the CBAC form. This time we removed the questionnaire. The government has a paper called a Community Basic Assessment Checklist, a form that has to be filled by the ASHA. We added 2 more questions to their questionnaire, and that covers our triage questionnaire. And so we said anybody who has an abnormality in the questionnaire or on awareness feels they have an abnormality, they self-refer themselves. And so that's what happened in Katlichera. So again, a similar population of about 66,000 people. They reached out to 48,000 people, out of whom 4,000 people said they needed further evaluation because they felt they had a symptom, they had an abnormality. And so when they came to the sub-center, again almost 80% of them reported to the sub-center. We referred about 10% of them to the hospital for further evaluation, but only about 60% of them finally turned up at the hospital. But we picked up about 100 odd cancers and 600, 700 pre-cancers. So we thought creating awareness may also be another strategy. Instead of the ASHA doing door-to-door awareness, her spending the time and effort on creating awareness may get us equally good referrals. Then again, the same HPV story, we realized in Hailakandi that if you offer self-sampling, more than 95% of women are willing to provide self-samples for HPV testing, but about half of them upfront don't want to undergo a VIA. And so we said, now in Hailakandi we had the ASHA alone create awareness. So we were wondering what happens if multiple sectors of the government have a convergent messaging, if the ASHA also, the police also, Anganwadi also, self-help groups also, various NGOs, if all of them give the same convergent messaging, will it improve self-referrals? Will it improve earlier diagnosis, or at least more people coming for early detection? And so that's what we did in, that's what we are doing currently in Lakhipur. Again a similar population, and we've trained all the ASHA. We are working with the self-help groups. We are working with the public distribution system. We said, this came from one of the participants in the Hailakandi study. They said, why don't you involve the public distributions? Everybody goes to a ration shop. So in the ration shops, we have put up posters, we are giving pamphlets. The idea of involving the Panchayat Raj, elected representatives of the local government system, also came from another participant in the Hailakandi study who asked us to get the Panchayat Raj people involved. And so that is what is happening in Lakhipur. And in Lakhipur, the project is still ongoing. We have not yet, we have another year and a half to go. So similar, all the blocks have similar populations, and so we have screened, about 5% of the population has come forward saying they have an abnormality. Again, similar outcomes, when they come to a sub-center, most of them report to the sub-center. But when we ask them to come to the hospital, a substantial number of them drop out of coming to the hospital. And then what happened is in Hailakandi, we did door-to-door awareness. In Dholai, we did door-to-door physical examination. Both worked very well in the research mode. So we said, what happens if we combine the learnings? We asked the ASHA to create awareness, and those who come forward saying those who self-refer themselves for further evaluation, what happens if the ASHA is the first responder? We combine what happened in the two programs. And so now we are scaling it up in 3 different districts, 3 different geographies, 3 different communities, in Kachar, in Karimganj, and in Dhima Hasao. And so we are looking at a larger population this time, and we are looking at training the ASHA. In Dhima Hasao, in addition to the ASHA doing awareness, we are also, because it's a difficult district to traverse, people have to go up and down hills and forests, and so we are going sub-center to sub-center. GE gave us a vehicle to constitute a traveling cancer clinic, and so that is added on to what is happening to the scale-up project. Finally, the scale-up project also, another 3 years more to go, but whatever preliminary data happens shows that we can look at different models to make things work. Finally, This is something that has been going on as a hospital activity. We have a very aggressive home care program for patients on palliative care. And so in villages, what happens when somebody goes for a home visit, several members of the village will gather to see what is happening. Something is happening. Somebody has come in a vehicle from a hospital. And so they are a captive audience. So once we finish the palliative care, to drain the ascites, control the pain, whatever, we gather all the onlookers and then do an awareness program with them, and then we administer the CBAC form, and through that program people will come and say, I have an abnormal. This is just an add-on to what is happening, because there is already a home care program. To add preventive care to them adds very little by way of resources, but has a lot of impact, both in terms of patients we identify and in terms of community build-up. I cannot complete a talk without acknowledging two of my greatest mentors, Dr. Krishnamurthy and Dr. Shanta. Dr. Shanta always used to say, our fear should not be the fear of cancer, but of the delay in diagnosis. For her, it was always every patient, everything for every patient. Thank you very much.
Thank you. Thank you very much, Ravi. Very inspiring. So I think we'll move on to the next talk, and then we'll have the discussion at the end of both. So could I invite Professor Emmanuel de Angel Antonio, please, from the University of Cambridge, to deliver his talk. Thank you.
Well, good morning. Can you hear me? Yes. And thanks for the invitation to speak at this very interesting workshop. Oops, I think. Well, hopefully I will get the slide. But what was keen to discuss is, shifting a bit gear from thinking about screening for cancer, what just been discussing about, to think about as well screening for cardiovascular disease, and especially focusing on one of the aspects about screening, really about how can we estimate risk in individuals, in healthy individuals, in primary prevention, and how can we use that for screening and prevention of cardiovascular disease. And I guess I think don't need to spend too much time on this. We know that cardiovascular disease is one of the top leading causes of morbidity and mortality globally. That's data from the WHO from back 2019. I think what is interesting is that not only is the top leading now, but they've been increasing over the last 10 years. So it is a problem, and it's a growing problem, globally. And it's globally, and as well it's actually not only sort of globally, but actually there's an uneven distribution of cardiovascular disease. So this is, again, data from a few years ago, but same data, I think, more recent data, really showing how, if you think about the death rate for cardiovascular disease, are quite uneven distributed across the globe, with a lot of events, a lot of mortality actually happening in many of the low and middle income countries. And I think what is interesting is that if you then look even deeper into within each of these countries, and here I'm picking sort of some of the largest countries, that actually this heterogeneity that we've been looking at globally is actually reflecting as well within each of these countries. So you can see that, for example, in US, as well in China, or here in India, there's quite a heterogeneity in terms of how cardiovascular disease, how death for cardiovascular disease are happening, in each of these places. Really think about, how can we address that issue, and how we should think about how you can take into account this heterogeneity when you think about cardiovascular screening in the general population. And the same is as well in Europe. Here's a map for men and women in Europe. So despite Europe is much smaller place, you still have that heterogeneity. In this case, you have really about east to west heterogeneity more the north to south, been changing over the last few years, really showing actually in the east part of Europe, the death rate for cardiovascular disease, both in men and women, are much higher than in the west part. And England is not different from that. Here's data from the 57 million people in UK, and this is a recent analysis on what is called the BHF Health Data Science Center that collect actually the data for the whole population. You can see that actually even within a small country like England, you can actually have a lot of heterogeneity in terms of cardiovascular disease. And here is not only in terms of cardiovascular disease, in terms of MI, myocardial infarction, of coronary heart disease, but actually you can get in many other diseases. So this is looking, for example, in this publication, looking about 79 different diseases, and now actually vary across time, but as well actually vary across different regions. So you can see that here's a map for MI. You can see the different region as well for peripheral vascular disease, how they can vary from north to south to east to west. So what the guidelines are telling us to think about how can we prevent or how can we address these issues. So there's a lot of heterogeneity, and actually guidelines really suggest to use prediction tool to try to identify people that will benefit the most for treatment. So this is, for example, both European and UK guidelines suggest to use what is called risk prediction tool to assess the risk of having a cardiovascular disease over the next 10 years, and actually to use that to actually think about some treatment decisions. So which one individual we should target for preventive treatment, in this case, mainly prescription of statin to lower cholesterol. And this model usually are very simple, use very very simple information, just few variable, in this case, age, sex, blood pressure, smoking, lipids, and diabetes status. So really simple tool that can be used at population-wide level. And so why this could be helpful? I think three main reasons why this has been recognized to be helpful. One is really you can communicate, so you can estimate and communicate risk to the individuals. You can actually motivate lifetime changes or change in their behavior and adherence to treatment. And actually you can allocate the resource, always limited, so as well in UK, but in any other country, you can actually think about using this tool to allocate treatment for individuals and really target to prevention to the people that will benefit the most. So in terms of risk tools, there have been many that have been developed over the last few years. For cardiovascular disease, I think if you go on PubMed, I think there are more than 100 risk scores that have been developed. Many of those are actually not used, not implemented. This is just a table summarizing some of them. I'm summarizing those that have been recommended by the different guidelines in Europe and North America. So for example, the SCORE model, the Framingham that was used a few years ago, the QRIS-4, the newest one in UK. I think QRIS is I think the NICE guidelines still recommend QRIS-2 if I'm right. The pool core equation, or the PREVENT one, was developed in 2024. But you can see that each of them are actually roughly very similar, maybe with the exception of QRIS. There's a richer tool in terms of using more information from the medical records, but the other use mainly the same type of information as I mentioned before, really age, sex, smoking. Some of them use BMI, some combination of lipids, and some other combination of some previous disease. So these tools have been recommended, they use different guidelines. One of the questions is what we should use, which tool we should use to predict risk in different countries. This is one of the questions that we've been asking. So one of the key aspects for my talk was really how they do this current algorithm. Can we compare them? And actually, can we do better than what this tool have been developed? And then the second question really, can we add information to improve this tool? Is it useful to add information? We hear yesterday from Riaz about potential use of genetics. I'll show you some of the additional data about how can we use this information to improve risk prediction. So let's start with the first one. How this prediction tool perform? Can we do better than this? How do they perform in different populations? And just to put in context, the idea is that for this talk is really to use three different measures of assessment. One is about discrimination, so the ability for this prediction tool to discriminate between people that will have or will not have an event. So rather than hazard ratio, I'm using C index. The reclassification, how can many people will be moved across different risk categories. This is a tool or a measure that I usually use to assess the benefit of allocating treatment in some way. And then third one is really about number needed to screen, really a measure of more public health impact, how many people we need to screen if you use one tool compared to the other. So these are the three main measures that I will use during my talk. So let's start with the first question. So the first question is saying, how does this score perform in terms of the risk discrimination? So, and here I'm assessing 4 of the summary score. The choice was, mainly for those that have been recommended by guidelines or have been suggested by the literature. And here, really comparing, some of the American risk scores, so the Framingham, the Poole equation, and the Reynolds risk score. There's one of them been developed a few years ago, and then versus the European one is called score 1. And so each of these comparisons was done trying to assess them on a. Does it work? No, sorry. So really comparing them, trying to compare them on equal foot. So it doesn't mean, so comparing them in what the outcome they want to assess. Each of them define the outcome in slightly different ways. So how do they perform? So you can see from this graph, this is a C index, so a measure of, as I say, on risk discrimination. They all perform roughly the same. And the change in C index is relatively small. So this means that each of them actually compared to each other, they don't vary too much. You can see that the C index change is very, very small and almost irrelevant from a clinical point of view. So how do they perform in terms of other measure? In this case, how do they perform in the number of people you end up treating, or the number of people you end up, or the number of events you potentially end up preventing? And so here, just comparing the same score, really in each of these different color, you have each of the 4 score. And you can see that if you look at each of the threshold, you can actually see there's a difference in the people that could be potentially allocated to one or the other treatment, or actually could be allocated to treatment or not be allocated to treatment. So if you think about, for example, a 10% risk threshold, you can see that the number of people you end up treating, going from score, for example, to the Poole equation, from the red to the green, you can actually have almost a 50% difference in terms of how many people you end up allocating treatment. And actually, this is reflecting as well in the number of people that you have end up preventing, or a number of events, you end up preventing, that the same threshold, you actually end up preventing a different number of individuals, or events, if you use one or the other. So this is basically using the original score, basically saying, can we use the score being developed and apply to a specific population? In this case, you're using a pool of different cohort, what is called the emergence factor collaboration, to compare all of this. And then if you then think about, rather than using the original score, you recalibrate, so you tailor those scores to the population you want to predict. So you use the incidence rate of cardiovascular disease and the risk factor level for that population to retrain the model, to recalibrate, to adapt the model to that population. You can see actually all of these are doing actually the same. So it's very difficult to differentiate each of the score when you recalibrate this tool. So really think about that rather than think about how this score perform, actually how we adapt the score to the population you want to perform. And actually this is an obvious, in some way obvious. You think about where this score been developed. Framingham was developed on a very small population, about 5,000 people in North America, so very limited from a geographical point of view. Here we're thinking, how does it perform in a much larger and much more general population? So you can see that the incidence of disease and the risk factor level are completely different. So once you take those into account, this score will actually be very similar. So what was our take on that once we've done this analysis? They really think about, this score. This score are usually built by different relative risk, and so that the relative risk usually are very stable across population. There are a few exceptions. I think Sarah suggested, for example, BMI, how they could be different between different population, but the majority of risk score actually, of risk factors, association between risk factor and disease are pretty much similar across different population. But the baseline risk in different population vary, and vary from population and vary as well with time. So something that's been developed 20 years ago is maybe not valid anymore. And then definitely, then the last point is actually that all of these models are actually used and developed using in cohort study. They are very selective and biased population. So how can we adapt to the general population where we want to apply? So our take on that actually that a key step in when you think about developing model is really about you should recalibrate the model to the population you want to apply that model to. So it's really important that your model is tailored to that population that you want to use in. And so on this, we develop a very simple framework of how we should think about developing risk prediction tool. So we're about different steps, about model derivation and model validation. Think about how you can derive and recalibrate the model to the population of your interest using incidence rate and risk factor level, and then how you can actually validate in external data, and then how actually you can illustrate how does it work in using different type of cross-sectional data on risk factor and incidence rate. And so using this approach, we've been working with the WHO a few years ago, using data from the emergence factor collaboration and then from the group burden of disease study, the NCD risk collaboration to recalibrate model, then to validate an external cohort, and then using the WHO steps data really to think about how this data can apply and how this risk model actually can work in different countries. And so we come up with this risk chart that now recommended by the WHO, in which we developed two different type of model. One very simple model, what is called a non-lab-based model. So that's include that without the need to laboratory measurements, so without the need to measure cholesterol or to assess diabetes. And actually a model that's slightly more complex, in which we have, for example, association with the cholesterol in, so in which you need a lab measurement to perform that. And this is actually implemented and by the World Organization globally. And as you can see from the map, these have been recalibrated. One of the key aspects being recalibrated to different countries. Of course, here the definition more than countries is actually of region of countries. So there are a group of countries in which we've been recalibrating to, given the lack of data for each of the specific country. But I guess I can show you at the beginning of this talk, really, we're not able to reflect the true heterogeneity of incidence rate, risk factor level within each of these countries. So it's still a step forward, but there are many other steps that could be done to try to tailor this score to the right population. And so what we've done as well, that was done with WHO. We've done a very similar work with the European Society of Cardiology. Here, rather than developing something more globally, we made focus on a European country. So we use very similar data and very similar system to think about how can we develop a score and validate and recalibrate a score to different European country. There is the different region that we choose for Europe, where sort of you can see from low to very high risk based on cardiovascular disease mortality, and you can see gradient from east to west. From east to west in terms of risk of developing cardiovascular disease. And again, this is the chart that we developed. This is again a very simple chart that can be used, in this case with the use of with a level of cholesterol and HDL. So with the need to assess through a laboratory measurement to assess cardiovascular risk. So, of course, this is just part of the story. You then need to implement this score now, both the WHO and the ESC score. The score is called SCORE. It's been implemented by different guidelines, have been implemented in different apps, and actually can be used and can be applied both for clinicians, but as well from the public. So these are tools that can be used to self-estimate risk and of cardiovascular disease, because many of these apps actually are open to the public. So, can we extend this approach to other countries? Show you how we can do that for globally, how we can do that for Europe. Do we need to extend to other countries? Can we do that? So we've been collaborating with different colleagues globally, and so these are two examples of what we've been doing. One is the extension of the SCORE 2 to the Asia Pacific region, so in which we've been recalibrating the tools to different part of different region in Asia. Again, this is a very crude approach to recalibration, because we've been using very large region or very large set group of countries to recalibrate. I think there's a lot of work to be done to move that to much more national or subnational level. And then we've been doing as well similar work with the WHO to recalibrate to China, in this case, more than recalibrating to China as a whole. We've been working to recalibrate to different regions in China. And so you can see how the performance of the score actually vary on the figure on the right, how the vary this is in women, has it vary in different province, and actually has it vary if you think about recalibrating to each of the province or recalibrating to the whole China. So actually you can prove the performance of this by thinking and using the estimate, the cardiovascular risk level and risk factor level for each region divided by rural and urban area within each region in China. So the next question we ask is that this is tool for general population. We usually use this tool for general population without individual diabetes. Can we do the same in people with diabetes? What do we need to add if we want to think about people with diabetes, given that people with diabetes might have higher risk of cardiovascular disease and might have as well other information we can use to improve risk prediction. And so the idea was to extend again what we have done in Europe, in this case the score 2, and really based on that model to extend how can we add additional information, in this case add information about age at diagnosis, HbA1c and eGFR, so a marker of duration of diabetes, a marker of the glycemic status, and a marker of renal function. Really, how does it perform when you add those information? Showing actually if you add the information, you can actually improve your model, especially improve your discrimination of this model, so will perform better individuals with diabetes. And actually you can see how this is reflected as well in the distribution of level across Europe, showing actually there's much higher risk of in people with diabetes. So actually you need to think about how to use this tool for guiding therapy, in this case not to guide statin allocation, but to guide allocation of additional treatment in individuals with diabetes. Just a snapshot of what we've been doing as well to think about what's next step. So next step for us has been, can we validate this model more extensively? Can you use larger set of data to think about does it work or doesn't not work? So this is data from, again, from the British Heart Foundation Data Science Center, which have been using information on 27 million individuals in England, so using electronic health records, and really think about how does it perform if you use this in the population, showing again that the model performed well, especially when you think about when you recalibrate the model to the specific population. So an additional example of how these tools are important to develop, but important then to tailor to the population you want to use in. So we discussed about how do they perform, how can we improve them, really through recalibration, but can we add additional information? There's a lot of discussion whether or not this tool should be, we should add additional expensive usually information. Does it work, does it not work? I think the jury is still out, but just maybe trying to convince you why we think about the jury is still out. So, and really starting with the genetic information, why genetic, why is such a potential interesting tool? I think the cost is going down and it's falling. So if you think about other potential biomarker, genetics start to be cheaper and cheaper. Can be done remotely. You can done we can done, for example, very rapidly using saliva rather than blood. So very easy and simple to collect, and as well as stable through lifetime. So once you collect, once you have information on genetic, you can use that long term. You don't need to remeasure every time. This could be pro and cons about using that, but definitely it's something that doesn't need to be repeated over your lifetime. And if you think about where we are coming from, so this is a collection of studies that were done before the development of polygenetic score. We have introduced the polygenetic score yesterday, so I'm not spending time about introducing that, but really think about polygenetic score as a collective of many information about genetics. So what we're doing before that, what we're doing before the, using so many information. So this is a table, back from more than 10 years, really showing how if you use simple information, simple genetic variants or combination of genetic variants for risk prediction for cardiovascular disease were not very helpful. So very few information is not really helpful to do that. And so this has been changing when we're moving to polygenetic score. This is the example of what has been done by Kira in Boston, showing actually if you develop this polygenetic score using not hundreds of variants but millions of variants, what's the advantage of doing that? And so here, the idea was that actually if you identify those people at the very end of the distribution, so really in the top, 0.5%, in the top 0.5% or top 8%, then you can see actually there could be an increased risk or actually a higher risk of developing cardiovascular disease. And of course, this is not in the context of what we're doing usually, so this is just in isolation, so without taking into account different risk factor. But if you take into account different risk factor, I think you see in this slide yesterday, you can see that even when you take into account risk factor, other risk factor, conventional risk factor, there could be an improvement of using genetic information in addition to conventional risk factor. You can see that from one of the last point on the figure on the left, you can see that actually there's a potential advantage when you add progenitor risk score to conventional risk factors. And if you think about does it help to improve or prevent cardiovascular disease? Well, if you put in the context of what we've been doing in UK, so using a 10% threshold, you can see actually you end up reclassifying some individuals. So there is a potential of preventing additional cardiovascular events in addition to using conventional risk factor. Of course, this is one of the challenges here. This is all data coming from one single study. UK Biobank, UK Biobank has been a fantastic resource, have been developed and used by many researchers, but still, this is an observational study. This is just one single study, and there are a few others actually proving that there are potential advantages using progenitor risk score. So how can you use progenitor risk score in a different ways? Rather than think about adding progenitor risk score at the end, you can think about why don't we add progenitor risk score at the beginning? So once we use progenitor risk score to guide screening more than to add to screening. And this is some of the work that has been done by Angela Wood, which really about thinking how can you prioritize screening and compare that using electronic health record only, or electronic health record plus genetic, or conventional risk tool. And it's really showing that there's not much difference if you use one or the other. So using a pre-screening tool, simple one, could be advantageous, but actually whether you use information on clinical records or information on clinical records plus genetic doesn't really make a difference, at least for cardiovascular disease. I guess here we're not considering the potential of genetics to screen not only for cardiovascular disease, but as well for screening or health screening for multiple disease, cancer, and other disease. So this is where we are in terms of the study at the moment. I think there's a big piece of information missing. What we are trying to do is bring some evidence to add on this. So this is evidence coming from observational study. We want to move that to a much stronger level of evidence, much more reliable evidence, as Sarah was mentioning yesterday. So the idea was being, how can we develop randomized clinical trial to assess the value of polygenic risk score? So this is a study that I'm running with some colleagues in Italy that has been really think about how can we define a population that actually are not usually eligible for statin treatment after cardiovascular risk estimation. And then how can we assess the value of using polygenic risk score in that, but actually how can we assess the value of imaging into that? So really comparing what we're doing now with the polygenic risk score strategy with the imaging strategy in the context of a randomized factorial 2x2 study. Really think about, can we bring that to the next step rather than sticking to observational level? Can we move to a much more reliable evidence, given that inclusion of genetic information in the NHS or any health system will be very costly and require quite change in the system that we're currently running. This is what I think we've been doing. Of course, some of the society have been moving much faster than that. This is just 3 examples from the ESC and as well for NHS that have been actually suggesting how we should implement genetics, polygenic risk score in this context. The first one is really a statement for the ESC, actually, in which myself and Riaz are part of. I think we've been a bit of in defense of how we should or should not suggest PRS, but there are other, the NHS health plan, they're actually really proposing how we should use that. I think in a bit, maybe we need a bit more evidence to implement polygenic risk score, especially in the context of cardiovascular disease. So just a few minutes, just the last couple of minutes. Is there anything else in terms of polygenic risk score? So should we stop at polygenic score? Should we stop at genetics? We still don't know what the genetic will bring to us, but there's, in terms of research, there's many other potential other markers that have been evaluated. This is, for example, using, again, from UK Biobank, a metabolite score, using what is called the Nightingale biomarker panel. This is about 150 different biomarkers related to lipids and lipoprotein. Does it add a bit? Yes. Does it add a bit? Is it comparable to polygenic score? Yes, it's comparable to polygenic score. Does it provide orthogonal information? Yes, providing orthogonal information. But as it has a clinical utility, I think the jury is still out. I think we still need to define. I think really we need to move this evidence to a different level if one then to implement those in terms of clinical practice. Same for other biomarkers. This is the example of proteomics, This work from Claudia Langenberg, Queen Mary University in London, really think about how can we use proteomics, so many different thousands of biomarkers to predict cardiovascular, not only cardiovascular disease, but a series of different diseases. I think this is too small to read, but these are basically 67 different diseases showing actually how proteomics could potentially increase risk prediction. I think we're still very, very far away from what is clinical implementation. And actually, this is just an example of how we potentially use these tools in the future. But I think they still need to have a lot of evidence before moving this to a clinical practice. So just to summarize, I think showing you that there's tools available for risk prediction for health screening of cardiovascular disease. These are usually being developed in different cohorts, in different studies. They're recommended by different guidelines. I think one of the key aspects here is how we make them applicable to different populations, and so how we make sure that when we use this score, actually are tailored to the population we want to use in. I'll show you some of those examples. The addition of different information, imaging or molecular, I think is still unclear what will be the benefit. Hopefully will be some additional evidence from randomized trial that actually will move that in a different direction. And actually I was saying they really need to think about moving behind observational study, moving more in randomized clinical trial to evaluate our screening strategy and how we can improve them. And I'll stop here. Thanks.
Thank you very much, Professor Manuel. So I think now the floor is open for discussion and Q&A for both the presentations. Yeah, go ahead.
Thank you very much. Really great pair of talks, and in a way, if when I reflect on the UK situation and just the global techniques to identify disease, subclinical or otherwise, and risk, there's actually a lot of complementarity, and I think there is something that we're missing in some of the UK stuff that we could revisit in some of the strategies. Oh, sorry. Yeah. I might come back to some of that, but I just wanted to have a sense of what it was like for people in those communities that you were doing this primary screening for, in terms of their understanding of neoplastic disease in the first place. For example, the way I sort of kind of felt when you were talking, that there might have been people who had experience of, oh, my auntie, she had a malformation in her breast, and then a month later she died, and then some people came, and then she had and then other people, and then had an examination, and then she had an operation, and it was like, was there a community understanding? Firstly, you did a lot of great community work for accepting those kinds of interventions, but did the community understanding of cancer as a disease also change in that time?
Yeah, over the years that has happened. More and more people. So that change has happened over the years. That change is happening. There's a greater understanding in the community, and there is an easier acceptance to interventions when you suggest them, as evidenced by more people completing treatment that is in the hospital, but that is reflected in the community also.
The reason why I think it's such a great story to hear alongside Emanuele is that so much research in the UK now is not just encouraged, is mandated to be built on very strong public involvement and engagement. And I think we've talked a lot about inequalities over the last couple of days, and I think we, in our population data, although it looks like, we have vast amounts of great information, but we have vast amounts of great information in an uneven way, and potentially we know more about people that we already know a lot about, and there are systematic biases in people that we know less about. And I think community engagement and the kinds of things that are great lessons for us as well.
I have a question. So you said polygenic risk scores increase the outcomes by about 7% over conventional risk scores. Conventional risk scores have interventions like cholesterol and lipid, but also have simpler things like waist height ratio and age and smoking and alcohol. So how much do the tests add to a non-test risk score?
A non-test risk score in the sense of
That we don't. So in our communities, very large populations, to draw blood for everybody, test cholesterol, test is a difficult task.
Yeah, so that's why I think for the WHO tools we developed something that doesn't include basically any measurement from the blood. So it actually include, age, sex, smoking, BMI, blood pressure. So really something that can be done in the field and doesn't need to take a blood sample or refer to
how much
a lab.
does the blood sample add to, like you said, 7% for PRS? How much does it add to a non-test score?
So you mean the blood sample compared to a non-test score? So improve a bit, but not hugely. So I think the benefit of screening much higher than including a cholesterol level. So moving that, especially to the more remote area, having the ability to use a non-lab-based score, I think is essential rather than only restrict not doing that.
Thank you.
Thanks very much, Emmanuel. I think you know what I'm going to ask about. You're on 10-year risk, but have you looked at the risk of premature death or the risks, i.e. dying before 70, or the years of life lost instead of 10-year risk? Because nobody in their 40s is going to have hit the threshold, and yet they might gain many years of life if you started to intervene now. And the other question, which is similar, is therefore how much do these add over and above age and sex? You sort of like, you've got what's your C index if you just put age and sex, or even age, sex and smoking?
Yeah, so there's now sort of growing interest in terms of think about how can you predict longer term risk, so 30 years or lifetime risk. And there are now different tools that have been developed. I think one of the challenges, I think many of the clinical recommendations are based on 10 years, so how we switch to that. So it really sort of think about more than in clinician mentality more than more than anything else. But I think that's definitely what I think the field is moving forward. And not only in terms of assessing lifetime risk, but as well in assessing potential benefit of treatment or different intervention over a lifetime, over a longer time period. So that's the first one. The second one was more about how does it add this information in addition to age and sex only. So there is a bit of a improvement on that. Of course, I think something we could think about is, do we actually need to predict risk? We can actually allocate treatment irrespective of risk, so much more blanket approach. And I think the question is still out. I think it would be good to perform study assessing that. I think some of the modeling studies have been done showing that there's a potential benefit in events averted if you treat everybody above age 50 or 55. I think there the challenge is about more about medicalization, lack of tailoring to individuals. So I think it's more about public acceptance and clinician acceptance more than true prevention effort.
Just to ask, in follow-up, Emmanuel, I mean, I think Sarah's right. The risk scores really should be the appropriate of age standardized, because death rates approximately, background death rates will double every 10 years. So you're looking at that as one of the key predictors. My question is if polygenic risk score, other risk scores are really to stratify by absolute levels of risk, and those would be the patients that would then benefit from effective therapies. The most effective therapies we have still have reasonably low use of rates. Statins, for example, are only 30%. But in England, are those at higher, broadly, risk scores also the ones with lower compliance for statins, blood pressure, smoking cessation, or they tend to be better compliance, but they still have higher risk? I wonder if you have some population data on that distribution.
So no, that's a good question. I don't think we have. So I think we have, but we have a look at I think it would be interesting to think about the compliance of individuals according to their risk and how can we actually improve that. I don't think there might be. We haven't done that. In relation to age standardized, I think absolutely. So, for example, one of the approach that the European Society of Cardiology. So I think there are two ways in which we can tackle this issue about lifetime risk. One is really think about can we develop tools that actually predict their lifetime risk, or actually can we adapt threshold to the age standardized threshold. So that's a simple way. For example, the guidelines for the European Society of Cardiology, the prevention one, they actually adopt age threshold, age-specific threshold, in addition to providing a risk for lifetime risk. So basically, that the lower your age, the lower your be the risk threshold, acknowledging that a lot of the risk is carried by age, and so that if you want really to prevent at early age, you should start at the lower threshold for that particular treatment. So I think those are the two potential ways. I think from a lifetime risk estimation, there are still some methodological challenge that we should address, but I think is not as performing as well as the standard 10 years risk prediction tools.
So I'll just pass the mic to you, but my question was about whether the WHO risk score has been tested out in different parts of the world, because the differences in ethnicity and genetic background obviously could give you very different predictive scores. And as you mentioned, the need for RCTs to actually see if these improve outcomes ultimately, because of all the complexities of adherence to treatment and all of the other social factors. One would need to see whether these are both efficient and cost effective in a particular country setting, like what Ravi was talking about, the kind of cancer screening that could be done at low cost, and what the ultimate benefits, how many cancers detected early, how many prevented. So I think we need that kind of data also, let's say in a country like India, which very high NCD burden, and Anjana Mohan has joined us now, so we'll be talking, she's got a lot of data from India, so maybe can pitch in also into this discussion. But do you want to take another question, or do you want to answer that?
Happy to answer this one. So
yeah.
In terms of the WHO, so the WHO was developed using different cohort globally. So there are what is the emerging factor collaboration, so collect I think about more than 100 cohorts. It was validated and tested in 19 different studies across globally. Of course, it would be good to test even wider. So think about how does it perform. We should recalibrate. And I think as I was showing with the example for the data from China, actually, the score has been developed so that can be recalibrated in a very simple way. So I think that's one of the advantages of that tool, that it can actually, if you have incidence rate and risk factor level from any region, you can actually recalibrate that tool to that specific region. And we're showing that actually this approach performed pretty well. So you can actually, it's very simple for a country. It doesn't have to be cohort data, doesn't have to be prospective data, just need incidence rate and risk factor level to recalibrate. And actually, if you recalibrate, that will perform always better than not recalibrating. And if you recalibrate to a smaller region, it would be better than recalibrate to a larger region. So I think, for example, in the WHO, I think South Asian is all together, but I'm sure that if you recalibrate to different region in India, the model will perform better. And as you, more better than me, and as I was showing, India has a quite heterogeneity in terms of cardiovascular incidence rate. So I think, in terms of your second question about what we should think about screening, I think it will be very interesting to think about how can we actually test different strategies for screening. Can we test what we were discussing before, age and sex only approach versus a slightly more complex approach using a simple tool to, I don't know, maybe some other strategy. So I think it's something that we should do. I think, for example, in Europe or in UK, this has been proving quite difficult because people are used to this tool, so nobody wants to go back on that. But in other countries where maybe cardiovascular screening is not already implemented, there's an opportunity to think about what is the best way to assess that.
Great. Fantastic talks, as usual, from both speakers. And I guess just a quick reflection on the risk side of things. I think Emmanuel and I have been working in this field for a long time, and that question of do we need more and more data, or have we kind of got to a point where we know what we need to do, we just need to do it, kind of comes back to the fore. So I guess a question for you, Dr. Ravi, is you focused on cancer, but increasingly there are other priorities as well, right? So there's cardiovascular disease. In the UK, we have similar problems where we start off an initiative to say, okay, we're going to focus on cardiovascular disease. And then people say, actually, diabetes is just as important. Actually, renal disease is now just... And then you find that these programs end up becoming almost complete medical programs on everything. So how do you approach that? Because you focus very well on cancer, but if in 20 years cardiovascular disease is going to be a problem, I mean, are you going to wait till that happens? Are you going to start educating now? What's kind of been your approach?
So in actually one of our first studies, this came out. We identified about 50 cancers, and we are in a population of about 46,000 people, and we had 3,000 people with diabetes and or hypertension. And so that is something we have to factor in our subsequent, each one evolving from the other. Somewhere this fell off the table, but we have to get back to doing that. We have to start looking at, ultimately, most of the NCDs have a common set of etiological factors: tobacco, alcohol, dietary practices, preferences, amount of physical activity. And so when you tackle one, from a preventive point of view, you tackle all the others. But from an early detection point of view, also you have to do that, so which we have not been doing, mainly for want of funding.
Common resource questions.
How are you incentivizing the ASHA workers?
So when the program is on, the incentive is built in the program, and we have actually in the later programs, we have incentivized based on the stage of diagnosis. If they bring a pre-cancer or an early cancer, they get a higher incentive than when they bring in an advanced cancer. So this is as far as the program. Once the program is over, ultimately as an institution we cannot sustain financial incentives. So because we now have a policy that once we finish the program we cannot dust our hands and walk off. So we continue to maintain our presence in the districts. And so we use non-financial incentives, material, but some form of incentivization, recognition is a must, because that is how the ASHA earns a livelihood.
Yeah, as you know, the bane of many community programs is lack of sustainability. Once we withdraw the program, everything collapses, So I think that's a main challenge for many NGOs, especially because we don't have the continuous funding that the states have.
I did not bring that up in the presentation. One of the things we are doing in Katlichera is trying to get the community to adopt health promotion. But what we also realize is health promotion is not a need. If it were water or food, it would be a need and they would sustain it. So we are trying to steal some ideas from Kerala. They have a neighborhood networks for palliative care, and palliative care is a very big need in the community. So we are trying to create community ownership for palliative care, onto which we want to piggyback ride health promotion. But that is something I don't have data for.
Anjana, are you aware of any such assessment that's been done in India? Because we have a lot of surveys, we have the WHO STEP survey, we have the INDIAB study data. So can we look at risk scores and see how predictive they are for different parts of India?
So my experience is largely with diabetes. We have the Indian Diabetes Risk Score, which has then been later taken up by ICMR and validated for the whole population. And our experience with risk scores, especially in India, are as follows. it has to be as simple as possible. So adding a lot of variables in and getting it just gets you into the non-compliance space. So in the Indian Diabetes Risk Score, we just have 4 questions and a waist measurement. That's all we have. So it's about family history, age, parental history, and physical activity, occupation. How active are you? 1 waist measurement, that's it. With that you score, it's non-invasive, and it gives you a fairly good idea, 60-70% sensitivity, specificity range, and it's enough as a first stage. When you have 1.44 billion people, that's about all you can do, typically. And after that, if someone scores, you see all the lows, you can just ignore, because they're definitely going to be, it's specific enough for that. So it's going to be all right. But if you're in a moderate or high risk, then the next evaluation sets. And so we've shown that the number of GTTs or blood tests that we need to do comes down quite drastically with this kind of non-invasive first step screening. So that is in the diabetes space. In the cardiovascular space, what we found is that, I'm not too sure about the WHO one, but we evaluated in a diabetic population the Q risk and the FRS. And they're very complicated scores. They require a lot of variables and things in it, making it highly complex. But of the 2, the Q risk was slightly better. That is what I think you also showed. I'm not terribly aware about the score 2, I'm sorry. And I don't think there's a regional specification for WHO to the best of my knowledge. So it just tells us that there's a lot of scope to develop these things further, especially since we see, especially with diabetes, there are huge ethnic variations. So if you have something that's in a Caucasian population, it doesn't necessarily, in fact, it doesn't work in ours at all. And that underlies the need for more specific or ethnic specific, exactly as you were saying, ma'am. So.
Yeah, thanks. I think there's definitely scope for more research. Yeah, go ahead, Ravi.
So how do you recalibrate a score for a region?
I went to the gym this morning, so. So the system we have developed is that you actually need age and sex specific incidence rate of that particular population of cardiovascular disease or whatever disease you're interested, and then the age and sex specific risk factor level, average risk factor level for that population. So once you have that, you can actually recalibrate the tools that we have developed. So WHO is very easy to recalibrate, and actually we have developed a program, in Stata, but you can adapt in R, whatever you have, that can actually use the original tool and recalibrate very easily to that. That was actually our purpose, that not to develop something that is being used, can be used as it is, but actually that can be recalibrated over time, but as well, in different regions. So, and I guess it could be different, India or different sub-region in India or any other places. So I think that's what we developed.
Thank you. I guess this is probably more just a reflection on the discussion from both speakers. There's a challenge here, I think, both of literacy and health literacy and numerical literacy when you're trying to explain risk, as well as trust. Because I guess you can imagine where people don't understand all information, you need to acquire trust to your doctor to kind of give you the best advice or manage your diabetes. Maybe in the UK population, there's more of a question about, actually, I want to understand everything before I can make that decision. So in a world where we are facing this challenge of trust, where people are getting information from other sources, are we behind the curve here? Do we need to kind of rethink how we educate our population, how we communicate risk, how we get out there to help people? I know in Cambridge, David Spiegelhalter did a lot of work around communicating risk. But I just wonder whether that is probably the next challenge that we will face in this space, and be interested to hear your thoughts, both of you.
For us, it is easier because we are a hospital in the community. And the trust in what we say stems from the experience the population has in what they experience in the hospital. And so it is easier for us to build that trust in the community. But for an academic institution, it's a different, they don't have service to provide in the community. And so for them, it's a much bigger challenge, I would think.
I suppose I'm reflecting from a UK experience where, in our hospitals and patients now, we are increasingly facing this challenge of people questioning doctors, from everything. It started with COVID, but now it's kind of progressing to a lot of activity. Thoughts on that?
Yeah, so risk communication, I think, is an essential part. I think there are different ways in which you can communicate that. Yes, I think simplicity is the key one, because otherwise nobody. I think there's not only risk communication and understanding risk from the community, but as well understanding risk from the clinician point of view. I don't think that many clinicians actually are interpreting or using those tools in a correct way.
I think what Ravi mentioned about the 3 things when you did the ASHA training, the third was communication. I think that's often missed out in health workers' trainings. We train them on just the technical things, but not on how to communicate, what questions to expect, and how to exactly address things which they may or may not know. And that actually adds to the trust or lack of trust. How you communicate with your... nowadays, everybody is looking at Google and so on, and there's so much misinformation out there. People come with strange ideas. So, but Ravi is right that still I think there's a huge amount of trust in doctors and healthcare workers in India. And so if they are trained in good communication methods, then I think we can really do a lot of building. But there's a huge work to be done in health literacy in the community still. Yeah, there are a lot of myths and misconceptions about diseases, particularly cancer. Both the causation of cancer and the treatments for cancer. Lots and lots of misconceptions. You wanted to comment, Ramesh?
So I'm trying to tie in some of the talks that we've heard since yesterday and the 2 talks that we heard today. And a lot of our efforts seem to be quite siloed in its approach. We go to screen for cancer, we screen cancer, and we allow the other NCDs to get treated by the next center. And given your experience, Ravi, that you have probably 50 times as much hypertension and diabetes as you have as you have potential cancer, and the fact that half of them, even with a potential diagnosis of cancer, don't reach the subcenter or the hospital. I just wonder whether, given the approaches which Dr. Bhargava mentioned yesterday about this protocolized treatment of hypertension, which is pretty much idiot-proof, and the polypill approach or the polypill approach which Dr. Reddy mentioned, whether there's an opportunity to intervene at point of care as and when hypertension or diabetes gets treated, and instead of us sending them to a special... I know we are in the business of treating cancer, handling cancer, but probably might have a bigger impact if we were to look at it together, and even adding the risk score to it. And I completely agree that the simpler the risk score, the more practical it is. Whether there's an opportunity for us to create a toolkit for other hospitals or academic institutions such as yours in various parts of the country. If you want to control for cancer and other NCDs, this is the approach that we need to take. And it'll be a shame if the learnings that you had over the last 15 years took another hospital another 15 years to implement, because we need to create a toolkit that works and work with the government, especially with the increased number of health and wellness centers, even if you don't have the direct ability to treat hypertension and diabetes.
One thing I think is very important is we should work with the government. We should not try and replace the government. Otherwise, nothing, as she said, sustaining any activity will become a problem. And so, I think it's a great thought, like putting together a list of activities that must be done when we are in the community, because you don't want to have the same resources spent again for some other disease. I think it's a great thought.
Yeah, I think we've had some really good discussion on this, and clearly there's a lot of scope for further work in this space in different contexts. So we've finished with this morning session. I think we have a short tea break now. So if we can come back in about 15 minutes. So at about 5 minutes to 11, please, so that we can start with the next one.
Welcome back, everybody. So this next session is going to be on aging populations, which is affecting everywhere, I think, but to different extents, and with so dropping birth rates and then aging populations. And of course, it's great that people are living to healthier for longer, but then it causes different challenges as they age into different health concerns. So we're going to start with Professor Daniel Davis, who's going to talk to us about healthy aging in the population.
Thank you very much. So that was interesting. Thanks for the introduction and the opportunity to talk. That first question, we're definitely living longer, but are we living healthier, is one thing I'll try and get to straight away. But you're right. I mean, I've adapted some of this in relation to some of the discussions we've already had, so hopefully it will still maintain its coherence. But one thing that is really clear is that this 19th century view that demography is destiny, and that the age and the population structure that you have can determine policy implications 30 years down the line. Not that we always do that, and that the age structure of the world is pretty much set, and then the key things in terms of function and health and aging is not always about your chronological age. I want to talk a little bit about disease and how disease isn't really the central consideration when it comes to better living or universal aging, and then what a sort of wider view of function might give us in terms of how we capture the outcomes in population studies, and then maybe a kind of hint on how we might do things a bit differently. So I think the first thing to say is we should probably try and go beyond the idea of disease, and I think there's probably a whole literature on healthy aging as something that's actually completely different from the amount. It's not just the negative one of how much disease you have. I'm not really going to cover that particularly today, but I just want to say that for, if you ask geroscientists, what are the diseases of aging, they'll give you this list and they'll make this observation that almost all diseases apart from like pediatric neuroblastoma are strongly associated with age, Alzheimer's, cancer, cardiovascular disease, Parkinson's, and so on. And that geroscientists are very exercised by the idea that there might be common mechanisms that underlie why these diseases co-occur, and so strongly related to the number of years you've been alive. I'm a geriatrician, so I think in both at population and clinical levels of a different kind of continuum or a different kind of set of risks. That is something that is driven by disease in a large part, but not exclusively about disease, and that's this idea of function. And there's a sort of, you've got some icons along the left, which, on the right, sorry, that show, what people you might imagine of a set of 8-year-olds who are all the same chronological age, but might have very different biological degrees of fitness, and literally a hierarchy in that sense. So, what is a disease? We've got international classifications of diseases, and I guess the sort of classical medical school teaching is that it's a discrete entity that has, presenting symptoms and signs, which has a certain etiology and a certain pathogenesis, and that for the diseases that we know, we know relatively more or less about those things. For example, in a syndrome 1 where we actually don't know very much, the second line could probably describe most of psychiatry, for example. We've got a defined set of symptoms and signs, but we're a bit agnostic about what some of the etiologies and pathogenesis might be. Syndrome 2, the etiology is not quite known, but the pathogen, psoriatic arthropathy or something like that perhaps might be a good example, or there might be a syndrome 3 where you know a lot about the pathogenesis, the etiology, might like a Huntington's or something, and then perhaps the pathogenesis is less known. Anyway, this is just sort of the general model when you think of disease as these discrete things. But geriatric syndromes are actually completely different and the fact that this is now the majority presentation in high-income countries and increasingly in low- middle-income countries too, means that we do need a bit of a mind shift away from exactly just what diseases are, and kind of recognize that in terms of how older people start to fail, either quickly or chronically, that the Jenga, if you like, is made up of multiple etiological factors and interacting physiological pathways. So how does this work in demography of destiny? I think India has already reached probably its peak population, although median age here is quite, I think it's 29. It's pretty young still. It's not going to get any younger, and in fact, it's only going to age, and it's going to age pretty quickly. I think so, and of course, that median of India 29 is obviously not uniformly distributed across. There's a huge urban and rural gradient there too, as there is all across the world. And I think if we're probably going to reach world peak population in in probably all of our working lifetimes, arguably, and the predictions become quicker, sooner and sooner and sooner. So if we really reach, when we reach peak population, the key thing there's obviously a huge societal questions to ask there, but in terms of older age, it's not only is it an individual universal aspiration, but it should be a societal aspiration too, that everyone reaches older age as fit and as functional as possible. So this idea of whether or not longevity has been increasing for 200 years, and that's still, and I think even with some recent data showing that we might have reached the maximum or that some of those trends are reversing just in the last couple of years post-COVID. There's UK data for that. Essentially, the real question is, has health span kept up with lifespan? And that's what the compression of morbidity is all about. So assuming some kind of illness at time point X at the top, and then if you assume that there's some degree of illness is inevitable before death, pretty much, if you're very, in age, are we increasing the length of time? If the point at which illness onset comes and life expectancy goes up, you could be committing yourself to a longer degree of dependency. That would be an expansion of morbidity. The third line would be just a postponement of morbidity. And then the last one is a compression of morbidity, where we can increase health span, if you like, faster than the increases in lifespan. So the question, what evidence is there that either of those situations is playing out in populations? And I'm focusing on UK for the moment. So some estimates, and by some ways in which you measure multimorbidity, are suggesting that morbidity is actually expanding, and that it's set to expand. And that if you see this period of red, it's the period spent in ill health, and you can see from 2010, 19, 2040 onwards that that average life expectancy in the UK, it obviously differs a bit for men and women, but might be 83. But you can see that the onset of ill health might be even in as early as the mid-40s, and so people might be having 26 years in moderately ill health, and the average would be 12 years of severely ill health in the last part of your life. Those data are based on simulations from GP data and so on. Other data suggest that we have actually already achieved some kind of illness, some compression and morbidity. These are data from CFAS, which are cognitive function aging studies, which are UK representative rural and urban sites, sampling in the first studies which were reporting in the 90s compared to ones in the 2010s, sampling in exactly the same geographies, exactly the same methods for dementia ascertainment. And obviously dementia is not the only thing that is bad about older age, but it's one big dominating factor of later life. And what these show are age-specific prevalences by 5-year age bands. And if you can see, the blue lines are people born in 26 and earlier, and you can see that, that age-specific prevalence doubles every 5 years pretty much, from sort of 2 to 4 to 6 to 8, 16, something like that. But in the later born generation, 20 years later, there is much less dementia. I mean, this has never been something that been achievable by any of the the modern meds or the drugs or anything like that. This is obviously observational data, but it's pretty robust and has been designed to be robust to track those secular trends. So what that, in some respects, is a very good news story to show that age-specific prevalence of dementia and incidence has gone down in the UK, and that's consistent along, with Dutch data, with Swedish data, and even US data, which are obviously a very different healthcare system from Europe.
Sorry, Daniel, what is shown in the wild? How's morbidity?
It's the prevalence of dementia.
Dementia.
Yeah, which is not the only reason why we might be. It is a dominating thing for older age. So this is, in some respects, a great story, and there's lots of discussion as to what's different about cohorts born in 26 and earlier and 46 and earlier, and what might be relevant for cohorts born in 66 and earlier and 86 and so on. And I guess one huge societal, environmental, technological, industrial difference between those two generations in the UK are, if you think about as those generations got older, firstly, education, which we know is a very big protective factor in Alzheimer's, went up. That might be a cognitive dividend that the later born generation has benefited from. And we also know there's huge change in cardiovascular prevention that in the 80s and 90s, for the people born in the 20s, would have already been in their 60s and 70s, but in their 40s, do you see what I mean? Like that they were in a midlife enough to benefit from statin availability and much, much better blood pressure control. So that is also a good news story potentially, but there are two observations that I'd make. Firstly, for those of you who are surprised that age-specific prevalence of dementia has gone down in the UK, it might be because we have this wide narrative that dementia is this huge public health problem. And it's certainly true that the number of absolute cases of dementia has definitely gone up, but it's the denominator of non-cases, because these are age-specific prevalences, that's gone up much more. So you with me with that? So the percentage is down, the cases is up, but the percentage of the number of non-cases has gone up even more. So what that also is a story of, because you can draw a line and say, on that part of the bell curve, you've got dementia, sort of. Carol Brain would kill me if I said it like that. But essentially what this is showing is that the bell curve has widened. So this is actually a story of inequalities as much as anything. And the other thing that, before we get too celebratory about all of these things, is while the two generations do show what I'm calling a cognitive dividend, that dividend is actually quite modest given the vast change in the cardiovascular risk, cardiovascular treatment and prevention. So given, and we'll talk a little bit about the risk factors that have also drifted over time that might underlie some of these outcomes, the dividend has been less, and if we're starting to max out on some of the cardiovascular prevention at population levels in terms of smoking and so on, at least in the UK, are different questions around rising diabetes and BMI and things like that going to change that calculus and reverse these improvements. So risk factors over time broadly are thinking, the harmful ones, we know what they are, smoking, alcohol and so on, lipids, and the helpful ones, diet and exercise. They probably are all going in the right direction, but you can see that this is over time, right out to 2043. And so you can see that, obviously there's simulations and predictions, but the gains that we can make at the population level may actually be quite modest in years to come. And what I want to stress in every single one of these slides is that these are still what are reported as population averages, and whether or not, and how these stratify by socioeconomic class, by ethnicity and so on, are really, really critical, because the dividends that we might get are not evenly distributed across the population. And so in the UK, where we live, where we age, probably determines a lot about how we age as well. And there are very different public health pressures, and this is part of a lot of UK narrative around about neighbourhood type delivery, top-down type ways in which organising health and social care. But you can imagine that the determinants in terms of infrastructure, community engagement and so on are very different in across urban and rural and coastal settings. And one thing that we really we've talked a lot. I've sort of made the case. I've made some comments about the vast amounts of data that we have. There are still huge amounts of data that we don't really have. And although I'm showing you this as if it's all very, very, very clear, what we know, for example, on social isolation, which is such a cross-cutting issue for older people, and a cross-cutting issue that's very intimately related to health and social care use. And the more isolated people come, you can almost do zero prevention work in people who you don't know and don't know anyone else. And therefore, of course, people do present to services, but will do so acutely and will be 10 times more expensive than had you just known about it in advance. And the statistics are quite stark from what we do know, even though these aren't completely robust on data. So 1 in 5 people aged over 50 in the UK will say, I don't know enough people in my life. I know some people, I have a partner or whatever, but I don't feel that my day-to-day life is full enough with social interaction. There's a difference between social isolation and loneliness, which we can discuss if you're interested. But there are people who just say that 20% of people say, I just don't know enough people in my life. 7.5% of people will say, I do know people, but no one close enough to me that I can discuss finances, my health, and in return, and also no one who would be an advocate for me close enough who'll say, your feet need looking at now, or your house is getting quite cluttered. And there's just under 1% of people literally do not know another human being, and these are people who do come to attention to the councils because they have a funeral and no one is there to even come. They just have a public funeral, like a publicly funded funeral, but no one comes to it. So these are, you can feel sad about that as a comment on society, but as I say, for a policy point of view, this is very, very important to try and get a handle on because of all of the cross-cutting impacts that has for aging. So these are the data from across the country that stratify this life course outcomes, but based on inequality. So this is comparing the most deprived decile from the least deprived decile. And if you want to just read across any of those things, you can, if you read across here, for example, 50 to 54-year-old, in an advantaged place, more than half of them have absolutely no problems whatsoever. And then you're already at 90% to have some minor problem, and less than 5% have severe problems, and about 2% mortality. Advantaged populations. In exactly the same age, only less than a third have no problems whatsoever. A sizable number are dead. More than 5% are dead. And you can see here, only 3/4 have only trivial amounts of ill health at 50 to 55, which should be having the time of your life in your 50 to 55. So those are stark things that are really important to go beyond just the averages that you might see from population data. So to tie that together a little bit, as I say, just more than the counting of diseases and the risk factors that might underlie those diseases, it's important to count function. And as I say, that's a continuum rather than a discrete thing. And you can imagine that they're all on a hierarchy. So, if you know already that someone has got good indoor mobility and has got good stair and can do stairs, you probably don't need to ask if they can transfer. You don't need to ask if they transfer out of bed. It's logical that they do. And equally, if you know that someone can go shopping and cleaning, by definition, unless they are doing it naked, they can get dressed. And the opposite is also true, that if you know that someone can't prepare meals, then everything above that needs to be taken care of by someone. Either, I just knocked something, sorry. Oh, yeah, I got it. So why this also plays out in terms of prediction. So in Danish data, if you ask the question, if you take 90-year-olds in Denmark and say, what are the risk factors that predict you'll make it to 100? I mean, yeah. And you could postulate that those are things like having cancer, having smoking, medication, BMI, social class, etc. Diabetes. Well, turns out that those things actually don't, what each of those triads is showing you is an exposure gradient. And basically for men and for women, in fact, what in Denmark, what do you think is the chance of a 90-year-old making it to their 100th birthday on average? I mean, so it's actually about 10%, as you can see. So in men and women, it's slightly higher for women, lower for men, but about 1 in 10 will make it. How do you predict who those will be? It's not the amount of disease you have. It's not really the cancer you have or bronchitis or stroke. It's actually how well you perform on things like activities of daily living, chair stands, grip strength, walking speed, and those much, much more functional things. Those are the things that predict. So basically, the disease burden you have gets you so far, but in terms of really extreme older age, the much more kind of sign of biological exhaustion literally is the impact it has on your function. And these are things that if you don't measure, if you're only measuring disease, you'll miss. So instead of this strict idea of compression of function and morbidity or functional decline, this idea of compression or expansion and morbidity, probably if you think of function as a continuum, you're really thinking about trying to square a curve that's actually got on its y-axis this idea of activities of daily living, function and capacity. And that's not only just, as I say, a nice thing to know because we care about older people. It's actually a very intimately associated with their social care needs. So someone has to do it societally if someone can't do it for themselves. So that's just making the point again that it's important enough to think about disease, but function takes you much further and much closer to what the actual kind of social and health economic impact is. I've added this in because I think I didn't see any area for this discussion, but it's also a kind of a sign of where we are in the UK, and it might be a sign of where we would get to in India. And as those of you who know the UK will know that comparatively we have reasonably good data across different single unitary systems, although they're not as good as you might necessarily think. What I want to tell you about is some of the problems with diagnostic and long-term condition management practically in this example is North Central London. So it's 1.6 million people, of which 60% of European heritage. And though ethnic characterization, especially in London, is extremely complicated because we've got like half Argentinian, half Lebanese people, and in fact most of them, and I would say probably at least 20, if not % are actually not classifiable in a straightforward way, and I would be included there. I live near where it says 6 on that map. But there are 11 different providers of either primary care, social care, community care, and hospital care, and so on. And this is purely some data on how many outpatient appointments that people have. Now, so this is total outpatient office encounters in over 12 months. And you can see obviously most people have, I haven't included people who have fewer than 10, but in this tail end, you can see that there are nearly 15,000 people who have more than 40 outpatient appointments a year. And the top end is 420, but that's obviously a nonsensical number. That's probably people on dialysis or something. But there is a big chunk of 1% of people, but that's 15,000 people who are having more than 50 or so outpatient contacts a year. And if you map it by units of primary care across the borough, there's about 40 PCNs there. What I've done is I've just ranked them by the age and IMD, the deprivation index for that borough or that area, and just sort of and put one as a reference point to say, if you adjust for potentially need, age structure and deprivation, how much usage, how much does usage of outpatient appointments vary? And it varies a lot. And one of the implications of that is that if you look at, and this is a super busy graph, but what this is essentially showing you is that of people who are high intensity users who are using 40 or 50 outpatient appointments a year, only a tiny number of those are in one trust. You can imagine that those are people who are having like weekly cancer infusions or those kinds of things just in one trust. The majority of people are having healthcare delivered by a multitude of of NHS trusts, secondary care, and a multitude of community contacts as well, such that, you know, and we have the advantage of, you know, overview data systems. You know, you can look at echocardiograms from a different hospital, you can look at, you know, different degrees of, you know, in real time, but yet we still have this huge proliferation of healthcare use where GPs aren't really empowered to kind of stop this multiplication of, so the kinds, just to give you an illustration, the kinds of things I'm talking about are, you're known to the Royal Free, you know, to Hospital A's heart failure team, but you fall over outside another hospital, so they do another echocardiogram, they do another 24-hour tape. Then you come to a different hospital because you're having your hip replacement, and again, so they're doing another echocardiogram as pre-op assessment. You're admitted to a hospital acutely, and the resident notices that your hemoglobin's a bit low, and so, but not that low to warrant admission, so you get booted out and then have an outpatient endoscopy, but then the outpatient endoscopy gets followed up. And then there's this, in the same way that geriatricians are very good at reducing and rationalizing polypharmacy burden, there is this new frontier that some kind of generalist physician has to be able to be brave enough to say that this is, I mean, an obscene amount of healthcare use and arguably pretty low value. So, yeah, and then these are all people who are, this is the distribution of people who are seen in more than one place. They're seen all over, you know, they're all over the place, multiple times, multiple providers with no, and in theory, the general practitioner is supposed to be triaging some of those things, but they don't have the time, power, or even expertise to kind of make sense of some of those things. So it's a sort of a kind of, yeah. And then could you tackle this provider by provider? So this is the UCLH appointments of the last year, contacts, you know, nearly 800,000, and then only a quarter of them are only seen at UCLH, as I said, and then they're all, you know, then the second most common is somewhere else, and then the second most common, and then this is only in our ICB. As those of you who know North Central London will know that Barts is not even in our ICB, and neither is Imperial. So this is an underestimate of what people are actually doing, and so I think, you know, what is the power of understanding this from a kind of population perspective, is that you can, that actually, there's, if you take the population as your true denominator of activity, the first thing is just to describe what those, you know, the extent of the problem, and then you can start thinking about, you know, but that's all I'm doing at the moment, just describing the extent of this problem. And it's maybe a contemporary problem, but it's not a problem that's going to get any easier without intervention. Okay, so just to summarize, we've talked about demography as destiny, and that chronological age is one aspect to it, but it's by no means the dominating aspect in terms of what counts for your own experience of aging and how much that's going to cost you as us societally. That there's mixed evidence for whether or not compression of morbidity is happening. I think it probably is, but the dividends are not distributed to everyone. And that long-term conditions really need some kind of intermediate grip, which is not fully specialized, you know, tertiary care, and more than what primary care is able to do. And there is going to be a new resurgence of this kind of generalist physician, I think, you know, to be discussed. That's all I want to say on aging. Thanks very much for listening.
Fantastic, thank you very much. And so then we're going to keep the focus on aging populations, but now talk in more detail about cognitive function by Dr. Thara.
Tara. No. It was there yesterday. I loaded it yesterday. No. Yesterday itself I loaded it. See. You can search for it. It was there yesterday itself I loaded. Same day. Shall I bring my? Is there? It was there yesterday. I saw it. Let's say Tara.
Okay.
Okay, I have it with me.
Okay. Does anyone have a question for Daniel while we're waiting for the slides to get set up?
Daniel, that was very good. Thanks. Those frequent visitors to multiple clinics, do you have sense as what kind of broad disease distribution or underlying disease patterns they might have? That's one question. The second, is it at all confounded with loneliness, meaning it's a good way to have social contacts? And since I've got it, let me ask you a third question. Is any trials or evaluations of effectively sending primary care nurses or doctors to their homes and keeping them? I ask because in Toronto there's a new palliative program that precisely does that. The doctor or nurse comes weekly to the home to make sure patients don't go to the clinic.
Okay, I'll answer those. Thank reverse order. So the first one on anticipatory care and proactive care, and there are innovations across the UK that try to do hospital avoidance, and I think those have some degree of success. As ever, it's all about case selection and making sure you've got the right person, because there are obviously trade-offs between not sending in someone who's sick versus someone who is, and what the skill set of recognizing undifferentiated potential, the undifferentiated illnesses is complex. On the loneliness, all the cross-cutting things that are driving some of that overuse it's not patients, it's doctors that's driving it. And there are people who have multi-system diseases, Ehlers-Danlos and those kinds of things who crop up in multiple services, but that's a tiny number in terms of absolute. Drivers will be BMI, smoking, mental health, and those things, and also just repeated visits. I mean, I found people who were being followed up by 2 tertiary centres for their liver disease. Neither of them really knew that the other was even following them up, because you have 6 monthly notes or crazy amounts of overuse, because no one has that broad view, and that's all ages. The patients can't cope; they can't work with that degree of hospital visit use. And they're very disempowered to say no.
Thank you very much.
Yeah, I think we are set now. So as suggested by the organizers, I shall be talking about mental disorders and aging. Although we have been talking so much about NCD, nobody has really spoken much about emotional and mental disorders, which I believe is a major component of NCDs, and basically running through all your cancers and diabetes and hypertension and all of it. Anyway, so SCARF is a non-profit, non-governmental organization in Chennai, in southern part of the country, and we are a WHO collaborating center for mental health research and training. So if you look at mental disorders, 14.5% of India's total disease burden is caused by emotional and mental disorders. And it's a US 1 trillion global economic loss. I can never understand the trillions, but nevertheless, all I know is a huge amount of money. And 30 to 40% of reduction in complications in NCDs happens via early detection. And Therefore, integrating mental health into primary and NCD care is the most practical, scalable and very urgently needed intervention. So, I mean, you all know about secondary prevention. I shall skip this. But the reason I have this slide on is we need to remember that primary prevention is related to incidence, secondary prevention is related to prevalence, and your tertiary prevention is related to quality of life and disability, especially more so in the case of mental disorders. And if you look at, there is enough evidence to say that secondary prevention offers the highest return on investment for India's mental health system. So there's a huge mental health gap in India. I don't know how it is in the UK, but close to 70 to 90% of people do not receive any treatment. There's no time to go into why they don't receive the treatment. And we are terribly, terribly under-resourced as far as human resources are concerned. We have less than one psychiatrist per 100,000 population. And most of these psychiatrists are concentrated in the urban areas. And therefore, what can we do? I mean, we can integrate screening tools for depression like PHQ, GAD and so on into NCD and PHC. When I say PHD, I mean primary health center workflow. Train primary care teams for early identification and brief intervention. Use telemanus for those outside India. Telemanus is a program that was even inaugurated by the Prime Minister, where counseling is offered through telephones, and the district mental health program. And there are schemes like Ayushman Bharat Health and Wellness Centers, which we need to really take advantage of as far as mental health screening is concerned. Now, this is very interesting. I don't know how it is in the UK, but when attribution is a major issue in mental health, you know, nobody wants to say that it is a mental health problem. For patients, it is stress, it's personality, depression, workload, physical weakness. For families are the last to, accept that the person has a problem. They always say that, no, it can never be in my family is perfect. There can never be anybody with a mental health issue. So they say overthinking, or karma, of course, is a very popular Indian something that explains just about everything that happens in your life. What do doctors say? When I say doctors, I mean the primary care doctors. It could be thyroid, it could be vitamin, it could be any of these things, of course. But this attribution is possibly, or even what we call explanatory models, are possibly the most important things which determine when you seek care. What is a delay in seeking care. In fact, families get very angry with us when they say that your son or daughter has an emotional problem and they stop seeing us. Truly it's a kind of denial. And therefore, what are the consequences? There are repeated relapses, very poor treatment response, much more disability, higher caregiver distress, and lower likelihood of returning to work or education. This is a huge problem that we face every day in the outpatient department to convince people that there is indeed a problem. And again, when you look at challenges to secondary prevention in India, stigma and shame. Surely, I have been seeing people for the last 40 years. I think the stigma has come down a little bit. In the sense, more people are seeking help for mental health problems, but it is still very much there. Even to come to SCARF, because the label says Schizophrenia Research Foundation, they don't want to enter SCARF. They say, I don't have schizophrenia, why should I be here? So that's a kind of a stigma. Fear of side effects, it could be quite genuine sometimes. And it'll all go away. This is especially with young people, parents think that it's all because they're growing up and it's hormones or whatever. And over a period of time, it'll all go away. So as I told you already, that in the family challenges are denial, minimization, seeking non-medical remedies first. In the rural areas, 80% of them go to traditional healers or magico-religious healers. We have specialized temples and dargahs which deal only with mental health issues. So these are very often the first point of contact for people with mental health problems. Lack of awareness of services, of course, and there are plenty of system challenges. There's no routine screening, long waiting hours, fewer psychiatrists, fewer referral pathways, and limited mental health training for GPs. GPs are most reluctant to learn anything about mental health. They just don't want to do it because they don't want to handle people with mental illness. Therefore, they do not indent for medicines, and therefore they say, sorry, we can't treat you, please go somewhere else. You know, it's a huge system failure and a professional failure as far as I see it. So what is it that all of you commonly miss, you know? You might miss mild moderate depression, anxiety disorder, first episode psychosis, surely, alcohol use disorders, adjustment disorders, early relapse signs, postpartum depression. These are all ideal targets for secondary prevention, but very often they land up not with psychiatrists, they don't land up with mental health professionals. They go to every other medical specialist, make their rounds, and come to us only after like 3 to 4 months. So there are, however, quick screening tools. Some of you might have used some in your practice, like PHQ for depression, anxiety, alcohol, suicide. Suicide screening is becoming more important. There's a huge number of suicides in India, especially in the state where I come from, Tamil Nadu. It's called the suicide capital in India, and it takes very little time to ask somebody, but it is never asked because it's such a sensitive issue. No, nobody wants to be asked and nobody wants to answer right. However, there are early warning signs. Health professions should watch for decline in functioning. I mean, he spoke about it. I think functioning is key when it comes to mental disorders. You ask people, have you been working regularly? Have you been going to school regularly? Are you able to do your work? It's far more meaningful than asking them, do you hear voices? You know, which they're not going to say yes immediately. Then, of course, there are sleep and appetite changes, social withdrawal. Social withdrawal is now difficult because everybody is now withdrawn socially, and you know, they are wedded to their iPhones or whatever. You know, so social withdrawal is becoming more and more tricky now. Unexplained physical complaints, drop in performance. Again, if you see a child not doing well in school, you have to necessarily think of any emotional issue they may have. And of course, odd behavior or hallucinations, which are pretty easy to detect. But what works best? There's been a meta-analysis regarding secondary prevention, and it's the relapse prevention programs, family interventions. I want to tell my UK colleagues that 95% of persons with severe mental illness in India live with families. 95%, whether it is schizophrenia or dementia or depression or whatever. Even dementia, they are not admitted anywhere. You know, the families take care of them. Therefore, family interventions become extremely important. Then, of course, cognitive behavior therapy, family psychoeducation, integrated interventions along with other NCDs, and patient psychoeducation. So what works in India? I don't have time to go into all these models, but there are these models where lay counselors, like we were talking about Dr. Kandan's presentation, lay counselors have been trained. Then there are programs like Atmiyata. Then we have our own youth mental health programs. We have an app which is called the YES app, which we have used in colleges for 15,000 children, students, to screen them for anxiety and depression. Then I already told you about the Telemanus, which is a nationwide crisis line. So these are all possible, but they really need to be integrated and mainstreamed. Otherwise, they'll just be silos and they won't have the desired impact. As I said, we need consistent implementation. So I told you about the YES app. This is a self-screening app, and you will be astounded to hear that when we gave it for 15,000 students in colleges, 35% of them scored on depression. 35%, you know, which we were pretty taken aback. How is it that so many are depressed?
But the irony is that less than 2% sought help. So that is the kind of gap that you're talking about. That's the kind of awareness that you're talking about. And that is why I think secondary prevention becomes so important. So there are other programs. I don't have the time to get into them. And we also have a feasible model for first episode psychosis at SCARF. And again, depression and anxiety, you have to have a stepped care approach, brief psychological treatments, and there is enough evidence. There's enough evidence to say that all these things work. Of course, digital tools, you have the smartphones, the RCTs have been done, and there are enough WhatsApp counseling methods. But then all of these need to be followed up, and all of these need to be integrated and mainstreamed. And depression and chronic NCDs, why is it so important? 25 to 30% of cardiac diabetic patients have depression. Dr. Mohan's center has published a number of papers on prevalence of depression in diabetes. And it can really make your diabetes worse. Depression worsens glycemic and cardiac outcomes, doubles non-adherence. That's the most important thing. Cardiac patients do not swallow their medicines if they are depressed. There's enough evidence for that, and that is true for diabetes as well, and increases mortality. So as I said, routine screening in NCD clinic is an absolute must. We have in Tamil Nadu, we have a cadre of people called NCD nurses, but they know nothing about mental health. That is a sorry state of affairs. And coming to elderly, he gave the young man spoke very well about the elderly. I just want to say that focusing on the mental health aspect, 14% of older adults live with a mental disorder, and the suicide is something that we are seeing more and more, suicide among elderly. Previously, at least in Indian philosophy, we used to say, you should not kill yourself, then you don't go to heaven, you go straight to hell and things like that. But now a lot of elderly are killing themselves because of what he spoke about, isolation, social isolation, and there's nobody to help them out. So 1.1 billion people in the world are aged 60 years and older, and this number is going to increase. Even in India, in every family now we have somebody who is in their 90s. It never used to be the case earlier. So lifespan is increasing, but quality of life is not. So these are some of the figures for those of you who are interested: depression, anxiety, dementia. Dementia again is increasing. Two disorders of the elderly which are increasing tremendously in India are Parkinsonism and dementia. In every family you have people with both dementia and Parkinsonism. And of course delirium and psychosis. Social isolation that he already referred to, ageism, elder abuse. Elder abuse is becoming very, very common. On one hand, we say we take care of the elderly, but on the other hand, there are very passive ways in which we abuse them. Then chronic medical illnesses that they have, cognitive decline and bereavement. When you lose your spouse, then it becomes very difficult for them to handle their day-to-day problems. I must tell you here, I must tell the UK colleagues, that insurance in India, health insurance in India still does not cover mental illness. Although on paper, as per the Mental Health Act, it should, but truly none of the insurance companies are covering except maybe one or two, and therefore everything is out-of-pocket expense. If you have a fracture femur and you have an antidepressant on your prescription, they will not give you the money even for the fracture femur. That is a kind of, those are the challenges that we are handling on a day-to-day basis. So again, early changes are same like what I told you earlier: mood changes, cognitive impairment, social withdrawal, and functional decline. Functional decline is possibly the most important because the elderly person is not able to take care of himself. And again, the challenge in elderly is you have symptoms of mental illness often overlapping with physical ailments. And then there of course, there's lack of awareness, stigma, And there are very few older adult mental health services in LAMI countries. We do not have them at all, in fact. So intervention would be the same, community-based integrated care, a mix of mental health interventions and other supports. We have a pittance of, there's something called an elderly pension or an old age pension, which is an absolute pittance. I think it's some 1,500 rupees. You know, you can't get a kilogram of, just some carrots and cabbage is all that you can get with it. I mean, it's really so sad that that is a kind of pension that many elderly get. So financial insecurity looms large in their minds, and that is often one of the causes of depression. And housing, public buildings, transportation again, and social support. Like in India, many children are living abroad, so very often the parents are alone, you know, to fend for themselves, and they feel more and more isolated. So these are some of the other interventions that we have. There is no old age policy. I don't know, Dr. Soumya, if you know whether there is one in India, but I don't think there is a policy for elderly, certainly not for elderly mental health. So that is something that we need to work on. So what can we do? Implementation of a multidisciplinary care, monitoring mental health, regular targeted screening, and initiating referrals whenever required. And therefore, there are some shared risks and there are protective factors. I think I've already gone through all of them. But please keep in mind that if anybody comes with a whole lot of physical symptoms and somatic complaints, it could well be an emotional disorder or a psychological disorder. Don't send him for MRI and this and that, you know, and then finally they land up with the mental health professional. Again, I think I referred to this, stigma, workforce shortage, there's no routine screening, very fragmented referral pathways, more importantly, family denial, and then there are gender and socioeconomic factors. The women seek help much later than men. The women are the last to eat in the family, and when they become sick, they're the last to seek help. Therefore, this is a gender problem that we see both in urban India and in rural India, which we have to keep in mind. So there are national initiatives, true, I mean Telemanas, DMHP and so on, but we need to, there is no clear monitoring of any of these, therefore we're not sure whether they do work or they don't work, and we need to really have some strategic embedded screening into the primary health centers and having referral, and more importantly expand on community-based models like, I mean, SCARF has been doing, many of us, like the cancer model that was spoken about this morning. There are research gaps. There are no longitudinal relapse data from India. There are no cost-effective models. There is no youth intervention research is another area that needs to be worked on. Workplace is a huge thing by itself, and mental health is very often affected in the workspace, and digital tool evaluations. And research must drive national scale up. I firmly believe in that, but we need money for that. So the way forward, what is it we can do? Screen routinely, first be aware of mental health issues. That's the most important thing. It really has to get into your head. Then screen routinely, ask about sleep and functioning, watch for psychosis red flags, involve families very early, provide psychoeducation, use telemanas or other helplines, and refer early to any service. And small steps can create a major impact. So that's it. You know, that is probably the most effective strategy for not just mental health, but for all disorders. So that's it. Thank you very much.
Thank you very much. I just have one question before we start. So early on, you had a chart looking at the excuses that like the students gave or their family gave, or but one of them the student said was you had depression in quotation marks. And so are they self-diagnosing with depression and then being ignored?
Yeah, that's a good question. Depression is a kind of more accepted term, and probably they think it's less stigmatizing than mentioning other psychotic condition. So they just say he's depressed. That's more acceptable than saying anything else.
Does PMJY support
Which one?
Sorry, Ravi,
In a very small way.
for the sake of the...
See, but many of these things are there on paper, but to get translated into actual programs and on the ground is difficult.
No, they have packages, no?
They have.
So there are mental
There
health.
are, yeah. There are. But as you know, implementation is a problem in our country because we are huge, there are other barriers. But it is there. Training is not good, yeah. Because who are you training? I mean, that's why I believe, I was telling them that I have been lobbying very strongly with some colleagues like Dr. Patel, saying that we should have a parallel cadre of ASHAs for NCD, including mental health. Otherwise, it's not going to work. Just getting the ASHA to do one more is not going to work.
In Tamil Nadu, we have this district mental health program. Is it specific to our state?
No.
Across?
It's across the country. It's an offshoot of the National Mental Health Program.
Okay.
But our DMHP is better. In all the southern states, it's better than the northern state.
In terms of reaching the patient?
Yeah, in terms of the number of people available and the medicines that are available.
Thanks.
I was really struck by the sex differences. In received wisdom in frailty is that women live longer than men, but women live with a higher burden of illness for the same, and men die basically at the same level of illness, is more lethal for a man than a woman. And lots of people have wondered whether or not that's because men don't, at least in the UK, and I think in most of Europe, don't have as much healthcare contact as women. So I think it's the first time I've ever heard of a healthcare system where the women have less healthcare contact than men. And is that specific to India, or is it consistent across India? Consistent across ages and consistent across geography?
Well, I don't know if there is hard data on that, but I can tell you that it is also a very cultural kind of thing where women are masochistic, I mean, okay, I'll bear everything, my child should be all right, my husband should be all right, so I will go on and on till I really can't take it anymore. And therefore, if you look at help seeking, they come and seek help, not just for mental illness, for anything. They go later. I mean, some of my Indian colleagues can also contribute. That is the thing, and they will not eat till the entire family is fed. I mean, it's a cultural masochism, if you ask me. I mean, people might appreciate it, people may admire it, but the outcome is not good. That's what I'll say. I want to ask you about social isolation that you had. So how many of the elderly live in care homes and how many live in families?
Of the population over 65, it's about 5%. live in care homes.
5% live in care homes.
Of people aged over 65 live in care homes. So it's actually a much, much smaller problem in terms of the general population as people might think. But probably 20% of people are receiving some kind of domiciliary care that obviously is differently provided across the country. You know, but in central London, it's very common. 1 in 5 of my patients will have like once a day carers, 2 times a day carers that might be supplemented by family, but the number of people who don't have immediate family or contacts in London is probably disproportionately high compared to the rest of the country.
Are there other questions? So if you could specify one thing as your wish list, what would you most like to change in the system, make lives better?
I think it would be even better integrated systems for data, so that we're all looking at the same reference denominator for social care, for healthcare, secondary care, primary care, and then that's where it starts with a better data infrastructure, which we already have which is already so good in the UK, but we've already hitting the limits of what we can provide with the data that we have. So we need to take another step further.
Dr. Ravi had mentioned that there's a questionnaire that the ASHAs use, no? CABM? CBAC. And are there mental health questions in that? Or Dr. Tara, do you know if the ASHAs, like in the Makkale Tedi Maruthavam scheme, are there mental health questions in that?
But they never asked.
Then
It's only the first 3 questions that are asked about blood pressure and maybe diabetes. The rest are not asked.
The problem about the Makkale Tedi Maruthavam, it's all a voluntary health scheme. These are not paid staff.
they are. The women health volunteers are paid.
But it is only for the medicine delivery and things. So they don't do a whole lot of it. The main problem that we are having right now is that the ASHA worker is maxed out completely, and she already does too many things. So she doesn't want to be asking questions on mental health, which are rather delicate, take time, take trust, all of that. So like ma'am said, if you really want to get this whole cancer, diabetes, there are NCD nurses, but they're like offshoots of the ASHA, and they're just extra. They don't know much about mental health. They do very little. So I think there's an extra workforce that needs to be, if you just load the ASHA, that's not going to, the Makkale Tedi Maruthavam, the problem with that is it's mainly for this medicine delivery for diabetes, hypertension, and they do take a blood pressure, sugar, that much they do, but I don't think they do anything with,
They have 2 or 3 questions.
Yeah, but what Dr. Tara is saying, they never get there, and they don't pay much attention.
Part D.
Oh, part D on mental health.
D deals with little interest or pleasure in doing things, feeling down, depressed or hopeless.
The other thing, sir, that we find with these questions is when we ask them in INDIAB, socially, people don't, especially if you're in someone's home and you're asking this to one participant, the rest of the family is around, they'll just quickly say, I'm fine. So the answers that you get is that 80% of your population is a happy population, very healthy and feels the well-being is very high. That's not true. It's just the way it's asked and how it's asked. People just, say, yeah, I'm fine, it's okay. They don't really answer these. They may not even be understanding because a lot of these comes from the West. When you say hopelessness and all, translating that into our language itself is not easy. They don't even understand what you're asking.
The irony is when I spoke to the chief medical officer in corporation and said, why not you look at mental health when these people, he says, when they start asking mental health questions, that's a huge stigma, and they won't be let into the home again. That is a medical officer who is saying it. So,
So how do you train your social care workers in the UK to deal with mental health?
Workforce training is developing still, and frontline social care officers, social workers, may only not even understand, or may not even really grapple the depths of people's isolation and loneliness, which is not even before the mental health stuff too. I think mental health provision is patchy anyway, but it is sort of there, and GPs are usually the first people to do 90% of the mental health stuff in the UK. But yeah, it really key is giving people a template to even ask. One thing that has changed recently in terms of social work assessments is that instead of a big old checklist of, how long does it take for you to get washed, and is your vision okay, can you drive, and those things, is to have this thing called 3 conversations. I'll send you the link, but it's basically 3 leading questions about where the conversation is much, much more organic. And you can imagine that the analysis of those could be done by LLMs, right? But instead of, so that the social work assessment is much more about well-being and what do you do to make you feel supported, who do you reach out to, in a much more, less tick box question. So you could use the conversations much more informatively. It's a bit of a cultural shift, but that's definitely something that seems to be more popular now.
You mentioned LLMs, but we haven't discussed, I think the next room is probably discussing a lot of, and we should have had some joint sessions perhaps, to raise these questions of where LLMs could play a role and where they're dangerous or where they should not be used. And clearly we need a lot, because they would save a lot of time. Maybe people will have less privacy concerns or less talking to an app than to talk to a human being. So it could do it in your privacy of when you get some time alone and things like that. So you could see advantages of using that kind of a bot, at least to elicit the first set of, before the health worker then comes in with some. Because the average OPD in India, there's no time for a doctor to ask any questions or interrogate about anything beyond immediate issues. So having a chatbot at the back end, trying to elicit some of this information, which takes some more time and some detailed questioning. I'm sure there are studies going on around this, but I don't know if anyone here is aware of.
Your HPV screening, like a first tier, and then you can do the more detailed.
Then do the more detailed, yeah. Of course, then for that you need smartphone penetration, you need network connection, data and all of that. But if you had all of that, then you could possibly think of this. You'd have to train the LLM on locally relevant data. You can't train it on a Western thing and then use it in India. And it would, and in India we have this language, the AI, it's called the Bhashini, where we now have the capacity to use AI to translate into any Indian language. I think some 26 or 27 Indian languages. So there's a huge potential now that people can actually talk in their own language or even their own dialect and be able to engage with a chatbot. So given all of that, I think there's a lot of opportunity to use this.
Okay. Oh, it was you. Okay, Sam.
Yeah. Oh, mine was a simple question. Just, does anyone know what the smartphone coverage is now in India? Because I know, just because on the bus coming there were people living under the road, but I noticed one on a smartphone. So more than 80%. Yeah.
Overall, but yes, the non-iPhone is even in rural areas, 80% coverage. Good. We get very cheap smartphones, which are available even in the rural areas now.
So ordinary vendor, if you buy even a soda, can pay using this. Street shops, even a 1 rupee chocolate you can pay with that. Yeah.
Financial transaction is possible.
This has happened post-COVID in India.
It'd be interesting to know if anyone has thought of taking the Mohalla clinic setup that works so successfully in Delhi and actually adding mental health to it. In Iran, which has been generally viewed as having quite progressive community-based treatment. They have the SERAJ program, which effectively means mental health services or integrated primary care. And my personal pitch would be that this doesn't need technology. It needs a massive number of trained counselors to be on public payroll to work in primary care and to be the resource person that, and that's been the Iranian experience. And their rates of mental health treatment are actually quite high, as Dr. Thar would know. So that's very much the approach. I'm not so sure about the bots and so forth.
I was speaking to someone at the break, and apparently they had just had a session, and one of the talks was about dealing with grief through a bot where you could speak to your loved one. And so whether or not that was a positive, beneficial way of addressing the impact of grief, or whether or not it was just marketing at a vulnerable audience, and also a way that it just further pushes up the use of these models that have high impact on energy. So do have discussions with people from the other theme. Yes. Fantastic. We are back here at 1 p.m. where we have Dr. Anjana Mohan talking about adherence. Thank you.
Their WhatsApps. Oh no.
Oh, the mic? Yeah. Thank you, everybody, for coming back. So we have 3 more talks because we're missing one of our speakers. So we'll have a talk on adherence, and then we have 2 talks relating to how policymakers make decisions, maybe some discussion of how they should make decisions instead. But then after a networking break, then we're going to have a closing session, and the closing session is going to be combined with the other team. So I'm not sure which room it will be in, but I'm sure they will tell us at our break. So as soon as I get a thumbs up from our speaker that we're good to go. So yes, so we'll be talking about Dr. Anjana Mohan is going to talk about assessing adherence, and then we'll move into policy.
Okay, so can you hear me?
Yes,
Right?
thanks.
Yes.
Over to you.
Okay. So, good afternoon. I'm well aware that this is the post-lunch session, so I'm going to have to do my best to see that you guys don't fall asleep. Right, so I'm going to be talking about India's metabolic profile and health habits, lessons on adherence. So I'm going to be moving to this study called as the ICMR India Diabetes Study, or INDIAB study for short. funded by the Indian Council of Medical Research, and Dr. Soumya was very much a part of it, and the Department of Health Research, Government of India. It's one of the largest epidemiological studies on diabetes ever done in India. We've covered the whole country, so state by state by state, all the union territories, the national capital territory of Delhi, and we have about 1,20,000, that's 120,000 individuals. This number is further increased to 130,000 now with more data that has come in. It's a cross-sectional, door-to-door survey of individuals aged 20 years and above. So what we've done here, before I go into the main results that were published in the Lancet 2023, here this study is it's a metabolic compendium of India's 1.44 billion. So we have men and women, we have urban and rural areas, and we have sampled the population according to population size, geography, socioeconomic status, etc. So if you look at the sample, it sits on the census of India. So this was the seminal paper that came out in 2023, which talks about all of the metabolic parameters across the country, and this is pooled data from 31 states of the country. The prevalence of diabetes stands at 11.4%. We have higher urban prevalence compared to rural, actually it's double. But the thing to remember here is that 70% of India lives in her villages. So for every percentage or half percentage increase in rural areas, you're talking about absolute millions of people becoming a burden onto the healthcare system of the country. Now here are the maps which are color coded for prevalence. Red is 10% and above, orange is 7 to about 9.9, 5 to 7.4 is yellow, and below that is green. So what this immediately tells you is across the country, in the southern regions you see higher prevalence, northern regions there's high prevalence, and in that center there's a little bit of yellow and green, as you can see. But if you look at urban India, all of urban India has a prevalence above 10%, and actually the greens are coming from the rural parts and the central part of the country. So that indicates a very high prevalence of diabetes in every part of the country. Now let's move to pre-diabetes. So we know that in the natural history of disease, we move from normoglycemia to pre-diabetes to diabetes, and that is natural progression. Traditional teaching that comes from Caucasian literature says that if someone has pre-diabetes, 1/3 of this population will progress to diabetes, 1/3 stay where they are, and 1/3 can actually regress back to normal. But in Asian Indians, we know that more than 60% of the population actually moves forward to diabetes within a 2 to 5 year period. So now with that light, if you look at the prevalence of pre-diabetes, it's actually higher than diabetes. It's 15%. The other thing to note is that there's no difference between urban and rural areas. Equally high prevalence in rural India of pre-diabetes. Now look at these maps. What strikes you here? What strikes you here? It's the opposite of the diabetes map, right? Remember in the diabetes maps, this was the low prevalence area. So where diabetes is low, pre-diabetes is high. So what does that mean? It means it's like a ticking time bomb about to explode. So these are people, so the diabetes conversion has not yet happened, but these are people with pre-diabetes or moving into the diabetic stage in the next 5-ish years. And you must also know that this is the most populous part of our country. It's very heavily, densely populated, and more pre-diabetes here. You will see that these are all going to convert to diabetes in the next few years. The other thing that's of interest in the Indian population is that we have a clear shift to left in our age of onset of diabetes. Now in any Caucasian population, when does diabetes start? 50 years, 55 maybe. In our population, it starts in the age group of 25 to 34 years. Doesn't matter if you lived in an urban area, doesn't matter if you lived in a rural area, doesn't matter if you were man or woman, it still starts young. You can see a clear takeoff in the prevalence of diabetes. So we are shifting, we have younger diabetes, which gives you longer glycemic exposure during the lifetime, putting you at risk for all of these complications. The other thing that's very particular here is the BMI. Now, if you had to have a young person with diabetes in a Caucasian population, what would you see? You would see huge, massive BMIs, the Pima Indians and other people. Our average BMI in the young diabetic is 18. So look at 18 to 19 is your age of, takeoff for BMI. So we have younger diabetes, we have lean diabetes with a lot of beta cell dysfunction as opposed to the extra adiposity that is driving the epidemic of diabetes all in other parts of the world. So that was what we published in that one. So here we looked at the prevalence of diabetes according to the GDP of states. So that's how rich a state is. Now, traditional teaching says diabetes is a disease of the rich. So the more affluent you get, the more diabetes you have because you get obese, and that's on the causal pathway, the physical activity and all of that goes together. So in this publication, which was a few years before the other, this was in 2017, you will see that mostly that's still true. Higher the GDP, higher the diabetes, and that's at a state level. But then we started looking at the individual level, and these bars here are color coded. The pinks are the lower socioeconomic status. This is at the individual family level, and the blue is the higher socioeconomic status. This is the rural panel and this is the urban panel. Now take a look at it. In rural India, you'll still see more rich, more diabetes, right? So affluence and diabetes, that story still exists in most of rural India. But now I draw your attention to urban India. You'll see that in affluent states or high GDP states of the country, in urban parts of the country, we've started becoming like the West. So the richer people have less diabetes, and the less socioeconomic strata, that's where the diabetes is flooding. And that's where you see in most of your countries, that's how you'll see it, right? Poorer people have more diabetes. That's happened in richer states of our country. So India is like this melting pot of all kinds of things. And we have parts of India that look like Canada, yeah? We have parts of India that are so rural that we don't have electricity. And all of that exists in one country. So obviously our diabetes also behaves like that. The people who live in Canada behave like Canadians, right? And those who don't behave like the rest of us. So there's this whole, so this is called a demographic transition. And India is part of this transition. This is transitioning quite fast. So you'll also find aging is more in these parts of the country, whereas in other parts we still have infectious disease, maternal mortality, all of that exists as well. Everything exists in a mix. That was about diabetes. Now let's move on to obesity. The obesity prevalence is rapidly increasing. The national average is 28.6%, much higher in urban. Urban has about 40% prevalence of obesity overall in the country. And if you thought that was bad, here's abdominal obesity. 1 in 2 Indians is abdominally obese in urban areas. So that's 50% prevalence going up to 40% overall. So rural areas are not far behind. The more the obesity increases, more the diabetes will get pushed. All the pre-diabetics will start moving into diabetes. Hypertension, we're at 35% overall, not too much difference between urban and rural areas, 40% in the urban population. I'm not going to show you all of the lipids. I'm just going to show you the total hypercholesterolemia here. Total cholesterol, this is 24% overall. So a fourth of the population do have hypercholesterolemia. And this is for a huge country like India. This is the national kind of numbers. So you put all this together in millions, and this was published in the 2023 paper. We have 101 million people with diabetes. We have 136 million with pre-diabetes. Hypertension is at 315 with a whopping 350 for abdominal obesity. So all across the metabolic spectrum, you will see that this is rising. Across, everything is higher in urban areas compared to rural areas. And a lot of these conversions, more and more people are going through these transitions. Now, what about adherence to therapeutic goals? So we have a lot of this. Do people meet the A, B, C criteria of A1C less than 7? Blood pressure, we're being quite conservative here. It's just 140/90, and LDL cholesterol less than 100. So this is the publication that came on the adherence. So A1C, about 30% of the population, 35% of the population meets its A1C goals of less than 7%. So this is actually not much difference between urban and rural areas, which was quite surprising. We thought rural will be worse off, but actually they're a little better off than urban areas. This is self-monitoring. So diabetes is all about self-efficacy and self-awareness. So self-monitoring is not good. It's better, of course, in urban areas. This is for those with diabetes, self-reported diabetes. How many people do it? Only about 30% on average. And then, of course, if you were taking insulin, you were slightly better motivated to self-monitor. And the numbers are not great overall, but a little better in urban compared to rural areas. Blood pressure. 50% of the population meet their blood pressure goals. But I'd just like to tell you, this is a huge study. We had to do all the 31 states of India, which was no joke. And it took us about 15 years to do it. So some of this data is a little dated. Subsequently, in a few of the states, we have latest data that's a 10-year follow-up that we have. And it's quite appalling that a lot of this adherence has actually started coming down. So it looks good today, but it's actually halved in 10 years. So we really need to be thinking what it is we're doing. With a lot of this disease spreading, less people having good control is not a good story. And that seems to be the reality right now. This is lipid control, 60% for total cholesterol, LDL cholesterol at about 40%. So not great in the adherence space, worst with glycemia, little better with the blood pressure, perhaps the best with lipid control. Medication adherence, I must say that our data is not perfect in terms of our medication adherence. We're still looking at a lot of it. But overall, for someone who had diabetes and was prescribed medication for diabetes, 57% of them said they were taking the medication. We don't have pill counts. We don't have all that. This was a single cross-sectional study. If they said they were adherent, they were marked as adherent. So that's what it is. For hypertension, it's about 45%. But this data is still getting cleaned up. What about the spectrum of OAD versus insulin use? 81% of the population was on oral antihyperglycemic drugs. A small, very small percentage were on insulin. Perhaps we need to do better with that to get better control. I have better data from the PURE study in terms of adherence. The INDAB data is not that great, but their numbers do look somewhat better. This is for diabetes medications, and this is India. Again, here you'll see that it depends on the socioeconomic status. Better the education, better the adherence. Poorer the education, poorer the adherence is what we showed in PURE. And this is for hypertension. It's again pretty much the same thing. It's about 40% overall for both urban and rural medication. Right, so that was about adherence to ABC control and the risk factor, the medication. Now we move to risk factors. This paper came out earlier this year in Nature Medicine, which talks about India's dietary profile. So everything we eat in India is carbohydrate. You probably know that if you looked at the buffet a little while ago. Okay, 62% of everything the Asian Indian eats is carbohydrate in various forms. There's also a myth that if you eat rice, you're going to get a lot of diabetes. I don't know, have you guys heard that myth? Rice is associated with diabetes. So yeah, so let's look at the rice eating states of the country. White indicates white rice consumption. So it's mostly in the south and eastern parts of our country, with the central, west, etc. eating wheat. So these ones, yellowish ones, are the wheat. And the millet, we talk so much about millets, it's like a dot on the map. Hardly anybody actually eats millet in the country. So not to confuse you on this is the map of carbohydrate consumption across the country. Here on the x-axis you have the various, these are regions and states inside each regions across the country. What is really flat and common across the country is carbohydrate consumption, 62%, of which we then have the split of rice, wheat, sugar. So that's the split there. And you'll see there's a lot of up and down. Even within, you can't say the entire north eats something. The entire south, even within that northern, it'll go up and down. There's intra-regional variation. Some states have more of rice, more of wheat. Some have a mix. Some have thing, etc. So here are the highest and lowest intakes. But let's take a look at the added sugar. the national recommendations are that there should be less than 5% of sugar in your diet overall, in your total energy intake. How many regions actually meet this? Only 21 states have more than 5% of the 31. So that's only 10 states that meet your sugar recommendations. So in the north, all these exceeded. There's only one state that met it, Chandigarh. Tamil Nadu, for some reason, is within the sugar recommendation. And in the northeast, most of the states don't consume so much sugar. So the story here is that we have a lot of carbohydrate and a lot of added sugar in the natural diet that we consume. Now, what about millets? We had a year of millets last year. Government was pushing so much of millet consumption that you'd think that the entire nation was eating millets. Unfortunately, the data tells us that only 3 states have more than 30% of the population who were consuming millets, and that's Karnataka, Gujarat, and Maharashtra. Only these 3 states consumed millets at all. The rest of it was non-existent. Now, this is fat. Fat is supposed to be within 30% consumption overall. We are at 25%, so that's the overall fat is fine where it is. But now let's look at saturated fat. Saturated fat is 8.9% of everything that we eat, and the recommendations say that saturated fat should be less than 7% energy in what we eat. How many people meet this less than 7%? 4 states in the country. That's Jharkhand, Chhattisgarh, Arunachal, and Manipur. There are only 4 states in the country that meet the saturated fat recommendation. So what do we have so far? Lots of rice, lots of sugar, and lots of saturated fat. And then people ask, why is diabetes increasing in our country? Right? It's not rocket science, guys. So that's what it is. Now let's go to protein. The other one, which is very homogeneously low in our country. So what is the national average? It is about 12%. Where should it be? It should be at least 20-ish%. The national average is 12. Of this, 8.9% is plant protein. We're a vegetarian nation at large. 8.9 is protein. Dairy protein gives you another 2%, and animal protein is only 1. Of the animal protein that's consumed, chicken is popular, fish is popular, and eggs are popular. We don't eat much red meat. It's in double decimal, actually, what we eat. So red meat is not an issue. As you would talk about the various diets that consume a lot of, we don't have that red meat consumption at all. So the northeastern region is, so if you look at the prevalence of diabetes, maybe I didn't point it out that time, the least prevalence is in the northeast. It's one of the least prevalence of diabetes. Those are hilly states, and you may think it has to do something with the climate or the altitude or something. But actually what happens is that they have very high protein consumption. They eat a lot of rice, but somehow they're able to negate it by this extremely high protein consumption. It's the highest in the whole country. So because of that, we're not sure. There seems to be some association with lower diabetes. Dairy is in Delhi, Haryana, and Gujarat have the highest intakes of dairy. Again, when we talk about dairy, there's a lot of talk about dairy producing diabetes. In our country, dairy is consumed as milk and yogurt, curd. And these are the ones that are protective for diabetes, actually. So these states do have good consumption. I already talked about the animal protein. So what we show here is that any type of the carbohydrate, any type of carbohydrate, rice, wheat, whatever you're taking, has an increased odds for developing diabetes or obesity. So that's what you say here, diabetes, pre-diabetes, and obesity here. And you'll see clearly that increasing tertiles increase your risk. So higher carbohydrate consumption of any form. Also, the myth about rice versus wheat, because oftentimes wheat is a whole grain and white rice is a refined grain. So common sense tells you, the whole grain is better than the refined grain. But then what happens is that we tried substituting this rice with wheat. It didn't do anything. Your risk remains just the same. And the reason for that is twofold. One is your total carbohydrate intake is still quite high, and the other parameters are still low. The protein and the saturated fat is still high. Second is that the type of wheat that is available in the market today is no longer a whole grain. It is a refined grain. because they've refined it and they've milled it, and it's got small particle size, and it's increasing your glycemic index. So the type of wheat that is available is no longer healthy. That's available commercially in the market. So in this paper in Nature Medicine, what we proposed is as follows. So here's for diabetes and pre-diabetes. We have the same thing for obesity as well. If you just decrease we're a carb-eating nation. It's not going to sell if you say stop eating carb, right? So all we can say is that 5% of carbohydrate, if you replace with protein, any protein of your choice, it could be plant protein, dairy protein. In fact, the best combination is plant and dairy protein together. That has a synergistic effect. But if you like animal protein, then fish is the best. Chicken is neutral. Egg was okay. Red meat was harmful. So any protein, you replace 5%, just 5% of carbohydrate, and you decrease your risk of all of these metabolic factors. So this whole protein story has suddenly come out quite strongly, wherein you're eating a lot of other stuff, at least negate it with fiber and protein. So that's a story that's coming out of this. So this was published again. These are population level recommendations for change in the Asian Indian diet. And this is what it is. Currently, this is the intake of carbohydrate, protein, fat. This is what I just told you about. What should we look at for a healthy diet? So this is remission for diabetes. So moving back from diabetes or pre-diabetes back to normal, what should be done? About 50% carbohydrate, 20% protein, fat stays where it is, and fiber needs. This is fruit and vegetable, green, leafy fruit and vegetable. You get to doubling from 3 to 6%. So these are the new macronutrient recommendations for the country for overall health. So that was about diet. We now move to another area of mine that's very, very dear to my heart, and that's physical activity or inactivity, if you may. So this is again data from INDIAB, where we've looked at how much of the population is active. Take a guess. How much of the population do you think is active? 20% of the population is active. Okay? Any more guesses? 10. Okay, right. So these are the numbers of active, inactive, and highly active in the population. You're not very far away. A lot of the population is inactive. Now you're taking India as a whole. So you have rural areas, you're talking about fields and villages, we're talking about peri-urban areas, you're talking about urban areas, all put together, about 61% is inactive overall. So that's about 30% active. And if you look at highly active, it's really, really small. So what happens is, and of course, urban areas are much more inactive than you would see in rural areas. Now, if you notice, I'm not talking about exercise here, I'm talking about activity. Because here we're talking about NCD risk, and that is related to long-term activity. Now in India, you have to make this distinction. When I started this about 15 years ago, we tried to use the physical activity questionnaires that existed in the world, which talked about how much exercise do you do, how much do you sweat, etc., etc. We tried IPAC, we tried so many packs, we tried Beck's questionnaire, we tried all kinds of things. They don't work in our country. Simply because, you ask the question, what are the exercises that make you sweat and increase your heart rate? In India, you can stand in one place and sweat without doing anything, right? So none of these work. The guy, when we tried the first, I think it was the GPAC, I think at the time, and so the most activity we got was from a tea shop vendor selling tea. You know why? He's standing near the stove, and he's selling this hot tea, and he's sweating buckets. Okay, and so remember the questions were all related to all of that stuff. So we got some weird kind of results at the end of the day and realized, okay, this doesn't work in India. Doesn't mean that they're totally inactive either. They get activity in different domains. In India, people walk for transport. People walk, in other areas, but they don't really exercise. If you want to know the exercise, recommend thing, I'll show you that in a few seconds. So the WHO recommends that we do 150 to 300 minutes of physical activity, moderate to vigorous physical activity a week. So the new recommendation is closer to 300, which translates to 60 minutes per day for 5 days a week. Now, how many Indians meet that? I'll tell you in a minute. But there are also new guidelines about sedentary behavior, that is sitting, I did notice today, guys, I wanted to tell you that we actually had inside of this conference something to break sedentary behavior, and that is the lack of mics. So people were moving around to give each other mics, right? You noticed that all morning, and I was just thinking, that's really good, because we're breaking a lot of sedentary time, which is what we're supposed to be doing. Also, there's recommendation for muscle strengthening activities for 2 to 3 times a week. We are a sarcopenic nation. It's extremely important for older adults. For those who are talking about aging, we do have multi-component activities for balance, strength, and flexibility. So all of this are the recommendations. Who said 10%? Right? You guys were spot on, actually. So these are the number of people doing exercise in our country, meeting the recommendations of 150 minutes to 300 minutes of MVPA. That's about 10% of men and 3% of women. Okay, so I've just realized sitting here today there could be really differences between us and the rest of the world, where women seek more care. That's the first time I've ever heard that in our country. It's always been women seek less care, women don't do much exercise either. So that's very, very common. So we started off, and what happens if you do less exercise? You get more diabetes, you get obese, you get, you know, all of the NCD risk factors. So this is again from INDAT. So we started thinking about, before I go there, this is the basically heat map of all of the health habits, most of which I spoke about, some I didn't. So you have A1C there, systolic, diastolic blood pressure, total cholesterol, LDL, HDL. So we also have this Asian Indian phenotype in which we have very high triglyceride and very low HDL across the country. It doesn't matter urban, rural, and just the biological differences between man and woman. So that's HDL, triglyceride, smoking, alcohol, fruit and vegetable, and physical inactivity. And color-coded heat maps, guess who's all in red? Right, so physical inactivity, and these are the states, by the way, right? Across the country, doesn't matter what you did, where you went, physical inactivity was prevalent everywhere. The fruit and vegetable was also not great, but at least it was in orange. And of course, our HDL and things are biologically with the Asian Indian phenotype. So that's a quick heat map of the health habits across the country in the various states. So coming back to physical activity, we started thinking, okay, what is it that we could do to start making people more active? So how can we do this? So we did this randomized controlled trial. It was called the DCLIP trial. At the time, we took men and women with pre-diabetes and obesity and tried to prevent diabetes. It was before, you know, the main prevention trials came out. So we tried to take men and women, gave them supervised exercise, which were weekly classes, as well as dietary changes, and looked at prevention of diabetes, weight loss, etc. And we found there were plenty of barriers to physical activity. So if I asked you today, do you regularly exercise? How many people would say yes? Right, so even in this room of healthcare professionals who have an absolute, complete understanding of how beneficial it is to be active, we don't have 100%. So can you imagine in a lay population that's living in rural India, in some part that doesn't even have electricity, what are you talking about? Doesn't make any sense to them to tell them to do physical activity. And then we started looking at, so this is in DCLIP, what are the barriers to exercise, you know? And we suffer from this thing called excusitis, because we have plenty of excuses. You know, it's too warm, it's too cold, it's raining, it's shining, you know, I don't have any time. And especially, you see the white bars here, they're women. Women have this very specific tendency to have a lot of reasons not to exercise. The family takes her time and she never has time. You know, and there's a whole lot of things that we had to, even inside of our intervention, there were group interventions for men and women. We found that men were coming regularly for the classes, the women wouldn't come. Why didn't they come? Well, they were shy. They didn't want to, my husband thinks it's not okay when other men are there for me to be bending and doing all these things. So there were so many cultural barriers to physical activity for women. The woman is also center of the household, right? We were talking about why this woman is not seeking help for various reasons. First of all, she has physical problems. Then there are psychological problems, which nobody talks about. There are environmental factors, stressors, social norms, all kinds of things. Basically, she's at the center of this metabolic, problem that we have, because she's the center of the family. She's cooking most of the times, so that decides what and all the family is eating. She is also, the person who decides who's going where, etc. She's not active herself, she's not passing that down to anybody. So there starts the problem, and we decided to break the cycle. It was easiest to start with women and physical activity. So we then started thinking, what are the ideal features of a physical activity program that could be tailored just for women? We realized there were a number of things we had to take. It had to be innovative, it had to be interesting, it had to be sustainable to prevent NCD, less time. Women are very busy people always, so time is very important. It has to be socially acceptable. In a culture like India, you can't just say go to the gym. It doesn't work that way. Women don't go to the gym here. So socially acceptable, done at home is an extra brownie point, and it had to be fun. So with women, everything is a bit complex, so this is no different. We had an intervention that had to tick all of these points. So ladies and gentlemen, I would like to introduce you to Tandav. This is a novel physical activity program that involves high-intensity interval training in the form of dance. So this dancing in India is a culturally acceptable form of physical activity for a woman of any age. High-intensity interval training gives you the metabolic benefits for NCD prevention, fat loss, etc. It only takes 10 minutes to do. You need to do it only 2 to 3 times a week. And each loop, that is one routine, consists of 4 songs, which are the usual Bollywood, Mollywood, Tollywood songs. And by the time you're finished, you don't even realize you've burnt all that fat and you're on the way to NCD prevention. So this is started as proof of concept. We had to publish it first. So this was the first paper. We had to say so we had to choreograph, right, steps and things. It had to be high intensity. How it works is that there's a 2-minute high intensity bit in which your heart rate is about 80 to 90% for age. Then there's a 30-second rest where your heart rate becomes 50 to 60% for age. Like that you do 4 times and you finished one loop. And so it had to meet HIIT norms. So we started with women. And then we found Indian women were unfit to do HIIT. Nobody could do, they weren't even walking, leave high intensity interval training. So then we had to move to children. So these are girls we took in a pilot study, proof of concept, it's MRC funded, where these girls were only 13 years. They were also unfit, but at least we could train them. They were teenage girls. And we started with these 23 girls. We took them to the St. John's lab, Dr. Anura Kurpa's lab, put them on all the VO2 max, did all that stuff, and then said, okay, it met HIIT norms, and look at the heart rate. This is what keeps the fat burn going, the metabolic risk. So the heart rate stayed there for age. So that was the first publication. We then needed to take it to the population. This was in pilot mode. So then we took it to schools. So we took it to schools where we took 2 schools for, it was a randomized clinical trial which we published, and one school we gave the intervention, one school there was no intervention, and we published saying that we were actually able to see fantastic changes in body fat, increase in skeletal muscle mass. Sarcopenia is such a big problem in our aging population, and it starts here. And these are teenage children. So body fat percentage went down, waist circumference went down, body fat mass went down, step count of course increased, the girls were dancing. We also had increase in sleep, decrease in sedentary time, and they started eating less junk. For some reason, that whole happy hormone thing started circulating. Then they were telling their friends, and their friends were telling their friends. We had performances at Diwali parties. Moms started joining. It started becoming a movement of sorts. So you have thousands of girls and women and people, happily kind of dancing away. We've been in 3 countries now with Tandav. This is Australia. And that's the video, which is not playing. Sorry, video. It's just a short video. Sorry, the audio is not loud. Those are our kids in Anura's lab. So that is the Tandav initiative for women. Oh, it's playing again. Okay. Sorry. Okay. So yeah, so these we have regular classes happening every Friday, online and offline, just for women and girls. So I'd like to conclude by saying I think I've told you that we have a huge metabolic disease problem across the country. We don't have good control, adherence to our ABC levels. Medication adherence is not adequate as well, and we do need massive education awareness programs for prevention. Diet quality is not good. There's a lot of carbohydrate, a lot of sugar, saturated fat and low protein. This needs change. New guidelines are needed. We're going to start with the public distribution systems, because guess what we get in our public distribution systems today? We get white rice, we get oil, and we get sugar. So all this is free. And an apple costs 40 rupees in our country. So, so if you had to buy, you had 40 rupees with you, and you had to get 40 kgs of rice or one apple, what would you buy? So this requires change. Okay, there has to be a lot of cooperation from governments. Physical activity, very easy to say, go walk, start doing exercise. There's a lot of thing behind it. It's not so safe in our country, so there are so many things. And there's this traditional saying, if you go out for a walk, 3 things can kill you. Either the traffic on the road, a truck can come and hit you. You can breathe the air, if you're in Delhi especially, and die from pollution. Or if all of this failed, then you could have dog bite, because that seems to be the latest trend if you walk on the road. So we need novel solutions. Just saying go walk doesn't solve it, as we can see right now. So we need novel solutions, maybe like Tandav, maybe others, and all of this has to come together for NCD prevention in this country. Thank you.
Fantastic, thank you very much. And yeah, it looks really interesting. I look forward to looking at the website. So we have the opportunity to have a discussion now relating just to this talk, because this is the one for the session. So open it up to the floor.
So as you mentioned, there's a large vegetarian population. And vegetarian sources of protein are also very high on carbohydrates.
Yeah.
So how do you balance that out?
So that is a good question, something that we have now to deal with. Now, even among carbs, there are good carbs and there are bad carbs. So the ones that are coming from protein can be counted as part of the good carbs. So there's more work to be done on various sources of carbohydrate in addition to the total carb that we're talking about. So overall, if it's coming from nuts or it's coming from your pulses and legumes, that has to count as a good part of the carbohydrate and allows for an allowance of sorts. So you're right. We have to look at how to balance the carbohydrate protein, and that's, I think, the challenge that we're working with NIN and others now to start coming up with better formula for these.
And fantastic talk, learned lots from that, I think. So one of the questions I had is this idea about sarcopenia. And muscle mass and diabetes risk and so on. I just wondered, where you showed that protein intake was high, have you got sort of body composition measures that might show whether muscle mass is slightly higher, and that might be kind of the interacting factor here?
In INDIAB, unfortunately, we don't have body composition. It's just too massive a study for us to be taking out stuff like that. But we do have data on risk of fractures and stuff, which is a surrogate of sorts. We don't have exact body composition, but we have it in other populations, not in the nationwide. We do have it in diabetic populations, smaller cohorts, citywide cohorts. Yes, the data is available and links quite well.
So in the UK, when we do studies, I'm sure my colleagues will agree, we are very mindful about inequality and introducing inequality. So just kind of thinking about the dance exercise, now, I guess that's culturally okay for the vast majority of India, but presumably for sort of a Muslim population, they might be reluctant. At least they are in the UK, I don't know, because of the association of music and so on. Have you found that, or has that been okay?
Not at all. Not so far. We have girls of all socioeconomic. It doesn't have any barriers, right? So we have girls of all socioeconomic. We have government school girls here. We have. We don't have any distinction. So far, we have not. Maybe I don't know whether it's something that's more prevalent in the UK, but I understand what you're saying. I've not come across so far. We've had it in our yoga studies, not in the Tandav one. So we've done other studies as well on yoga and children. There we've had some resistance because yoga is generally linked to a Hindu kind of philosophy. So there has been some Muslim populations where they haven't been allowed to do so, but not at all for Tandav.
Thanks, that was a great talk. I'm interested in your diet stuff, because obviously it's quite different in the West. I mean, most of the nutritional epidemiology has come from Europe and the US, really, and probably dominated by Harvard, to be honest. So I think it's really interesting to see the difference in India compared to in those countries, but also how much, even here, you've got a lot of confounding with socioeconomic status, and you've commented several times, and I think probably you might be going to show it, so I won't steal your thunder, but the women eat last, yes. And those will be presumably the poorer women, therefore their diets will be poorer, and just sort of how here you're going to tease out all those differences.
We have shown, so the differences between men and women are definitely there. So whether it's urban or rural, the woman eats less nutritionally healthy stuff compared to the man. So her fiber is lower. Everything is low, but it's lower in women. The carb is, again, lots of times women eat the leftovers. It doesn't matter whether it's urban or rural. That happens a lot. So now when you look at it by socioeconomic strata, it only worsens. Because at least wastage of food in our country is not looked upon well. So in any household you see that, but in a richer household, they're more aligned towards getting the right proportions done so there's no wastage, or they can afford more stuff, so it's, in a poorer household, it's worse, definitely. So no doubt about that at all. But overall, even among men, it's not great. It's just worse off in women.
I think I was thinking more about your associations then with diabetes and with cardiovascular disease, that you've got very different sort of confounding in India.
Because of the diet. So
you know, in the UK, the poor people will be eating more red meat, more processed meat, and fewer vegetables. Whereas here it's the other way around.
Our overall risk is not totally different between man and woman for diabetes per se. Obesity is hugely different. Women are way more obese than men are. For diabetes, the risk is not that different. Men have more hypertension, but that's because of smoking. So with the diet, it's very difficult to make individuals simply because of the confounding. The mix in the diet makes it very difficult to tease out. We don't have red meat consumption at all, but the mix of the diet makes it very difficult to tease out individual components, and it's never one individual thing that gives you a final NCD. So we don't have a direct link for any of this, just directionality in terms of those who have less protein have more of this, etc.
Fantastic, Dr. Anjana. Do you have permission to follow up the 1.25?
We've done follow-up in 2 states of the 31, and Dr. Swami just said we're going to talk to DG about the rest of it. No, we don't have permission at the moment. We've just finished all the islands and everything just now, and we've done 2 states follow-up, but we're going to ask for more. We don't have anything right now for
Does the consent have permission to follow up and their mobile numbers?
Do you mean for a second survey or to use the samples we have stored?
I'm thinking very simply, if you go back to that whole cohort and call them now, what, a few years later, say alive, dead, hospitalized, not.
Yeah, so we did that for 2 states. We don't have the permissions or the funding from ICMR to go back yet. So
But you've got consent you have, it's just funding is the
from
issue.
the participant we have, but we don't have the funding to go back.
Oh, that's that should be such a fundable study to
So
follow
that's
up
what
that
we're
cohort.
hoping will happen. But we'll see. What we do have though is we have blood samples from 25,000. So we have blood samples in 1 in 5 and all those with diabetes. So we have stored samples also. We have whole blood, we have serum, we have all of that stored. But yeah, we don't have permissions yet to go back.
And the baseline survey was how long ago, roughly?
So it went on for 15 years. So it depends on when the state was sampled.
That's a very doable study, just calling and finding out alive, dead, hospitalized, not.
Yeah.
Just one clarification. Threshold for A1C, that's 7.
Yeah.
Any thoughts on that number? 7 is
For control?
No, for classify someone as diabetes or not.
The diagnostic classification is 6.5 for diabetes and 5.6 for pre-diabetes. In our country, we don't use A1C for diagnosis for many reasons. Our assays and our anemias and all of this interferes with the A1C assay. We don't use it for diagnosis. This was for control. So for those with diabetes, how many? So
6.5
is the diagnostic threshold.
So I want to know your comment. Is it too restrictive or?
No, 6.5 is the one that has been used world over. Just that we don't use A1C for a number of reasons. We have an artificial elevation of our A1C. So if you use A1C as a cutoff, this 101 million will go to 204 million. We have a doubling of our prevalence if you use A1C in the diagnostic criteria. So for Indians, that's not advisable. We use only the glucose values. So these are based on GTT values.
Have you compared the glucose versus?
Yes. And got into a lot of trouble with the ministry because, do you know Majid from the NCD risk? Yeah. So we published in the paper, everything is there, the A1C value, the glucose values, and he picked the A1C value and declared one number for India, which came up double. I'm telling you what the number is, right? It was double the number that was declared, and it was a hue and cry in the ministry. And he did it 2 years after this was published. So this year. And they're like, in 2 years, how can there be a doubling of the population with diabetes and this and that? Nothing. It's just an A1C figure that they used. It's the same study, same values. But A1C is not a good way to measure for us. So it's not used.
Can you say why?
Yeah, there are a number of reasons. We're still figuring out if there are more reasons. Definitely anemia is something to do with it. We have very high prevalence of anemia across the country. In the eastern regions, we have a lot of hemoglobinopathy, which also interferes with our assay. So that's that. The standardization is not a problem here because everything was done in one lab, but that is an issue for in general sense. But more than anything else, we're trying to see why it is that we do have high fasting blood glucoses and A1C values. So if you just take the A1C alone, for some reason, I don't know the exact reason, these are all contributing, but how much they're contributing, we're still working on it to see why exactly it's becoming elevated. It's been shown consistently in our population. So I don't know the full answer, but these are the possible reasons. Yeah.
Usually when you go to a hospital and doctor for checking,
we use it in combination. We used it with an OGT for diagnosis. OGTT plus A1C is fine, but not on its own.
Can I ask more of a historical perspective? I mean, Indian diets over the last several hundred years, have they changed significantly? Because the easy thing for us to think is in an urban society, chairs going down, in cities, is because of the influx of Western food and so on. But I guess rice and things that have been eaten for many years and generations.
There's a lot of contributory factors to these in particular. What you're saying is one contributor. If you look at the diabetes, I don't have the slide here, but India's economy opened up in 1998. That's when the economy, our globalization happened. You will see a steep rise in the diabetes prevalence, obesity prevalence after that. So there's definitely the influx of these Western things and foods and all of that has its role. Having said that, other things have happened as well. I saw Dr. Soumya Swaminathan's father was responsible for the green revolution in this country. So our diets historically have been made to face famine, to do stuff that's very high in carbohydrate and fat and things like that. Today, we don't have any of all that, right? India is a fed country. She feeds herself. She's able to export food. So now, if you maintain the same kind of nutritional composition, it doesn't work. Also, the industrialization has brought down the physical activity levels even in rural areas. Nobody is walking in the fields behind bullock carts anymore. Everybody is inside a combined harvester pressing buttons. So the physical activity went down, the diet has to go down proportionately. You can't have the same thing and then expect. So obesity levels are increasing. Add pollution, add stress, add migration, add all of these things. I think it's a combination of a lot of these factors.
Okay, thank you very much indeed. So now it's sort of a transition session because we're going to end up speaking about policy tomorrow as well. And there will be details to follow for those who are taking part tomorrow. But we're ending with 2 sessions answering the question, how do policymakers make decisions? And so the first one will be Professor Prabhat Jha from Oxford, who's going to be leading the way, and I think echoing some of the things that we've already had introduced.
Very good. Thank you to the organizers for inviting me to this meeting. I'm going to build upon a couple of the previous discussions and presentations to just give you an overview of the trends in vascular and neoplastic mortality, what we've learned from the Million Death Study. And then I'll briefly talk about risk factors and talk about what might be done. I know this session is about what policymakers should listen to or what they should do. Well, I think they mostly should listen to the previous speakers in terms of what might be done. So let me start with my conclusions, which is that within India there's extraordinary variation in cause-specific mortality, and I'll give you examples just for vascular and neoplastic, but it certainly applies to other diseases. And I think, as Dr. Lewington alluded to yesterday, vascular mortality has quite inexplicable distributions just in terms of the cause-specific patterns, but also key risk factors. And you have this paradox of low body mass, but reasonably high levels of fat and a different association with vascular mortality than is the case in other settings. I'll briefly talk about lacto-vegetarian diet, particulate matter, and most importantly, smoking. And finally, I'll make the point that India very much could benefit from having large-scale blood-based epidemiological studies, such as which is underway with Dr. Pramesh and Rajesh Dixit and others, called the Indian Study of Healthy Aging. But it needs the equivalent of UK biobanks or Chinese Kadori biobanks to really understand this complex epidemiology. Okay, so the starting point of much of my work has been around a simple problem: how do people die? And surprisingly in the world, of the 50 million deaths that occur every year in low and middle income countries, half simply do not have information on what killed them. India was an example up until recently. It has about 10 million deaths a year. Only 7 million are registered, which just gives you information on whether they are traumatic or not, but no medical information. And only 1.3 million are medically certified. And the undercounts, the missing information, is greatest in females and is greatest in the poor areas. So what's the solution? Well, when people start dying in hospital and you have good hospital-based systems, you can get good medically certified causes of death. But in the absence of deaths occurring in hospital, one solution was actually proposed by the Sanitary Commissioner of the Government of India more than 140 years ago, which I'll let you read. But effectively it says, ascertain the mortality in small areas, see how they arise from preventable causes, and to apply the remedies. That effectively is the million death study in India. So what we've done here is collaborate now with the Registrar General for over 20 years. I started working with Jayant Banthia after the 2001 census. I first approached him in 2001. He said, go away, I'm busy with the census. I called him in 2002 and said, all right, we can talk. And what we began is in the sample registration system, which is India's ongoing robust system for demographic fertility and mortality rates, we introduced a verbal autopsy. And a verbal autopsy is a structured, careful investigation of the deaths that occur with some standard questions and, importantly, a local language narrative. And so 900 non-medical surveyors were trained about 3 or 4 times, and they've moved now to using electronic entry. They're doing the work on paper. And then we trained 400 physicians that were able to code these records online. They basically got e-records. And the doctors were treated like laboratory rats very strictly. You have to have agreement with the other physician, and if you don't, you get each other's guidelines or each other's keywords, and continuing disagreements go to a senior physician. And to that, we've recently added, not in India, but outside, GPT as one of the additional third diagnosis of physicians. And the approach was to study all diseases, keep costs very low, and so far it's now up to about 0.85 million deaths. It'll hit 1 million deaths soon. And these solutions have also expanded elsewhere, most notably Sierra Leone. So what did we find? Well, lots of things that we didn't expect. And this is an example of some of the unexpected results. And the key I would like to emphasize is each common disease was rare somewhere else in India and therefore must be avoidable. There are important correlates of disease in the population that predict either risks in individuals or rates at the population that we simply do not know well. And let me start with some nice work that Usha Ram had put together, looking at not just the MDS, but all the mortality survey sources, and said, what's the variation in childhood and adult mortality across Indian districts? And for children, you see, which is mostly concentrated in below age 5, you see this well-described north-south pattern. This is well known, that the poor states, the Bimaru states, as they're called in the north, have the highest child mortality. Lowest child mortality is in the south, like in Kerala. But for adult mortality, 15 to 69, it wasn't so much a north-south pattern, but interestingly an east-west one. And if you then say, okay, can we explain that variation in child mortality by simple things like maternal education, access to vaccines, and a few other key indicators, about 70% of that variance you can explain with known predictors. When you try to do the same for adult and you throw in things like smoking prevalence or alcohol use or healthcare access, it doesn't explain much of the variation. So we don't know why there's this remarkable variation. Historic plots would tell you this actually overlaps strongly with presence of long-term malaria, So there might be long-term consequences of childhood infection that lead to adult diseases that we don't know well. Okay, let me start with vascular disease as the leading cause of death. So in 2015, there were 1.3 million vascular deaths, but 0.58 million in men from ischemic heart and 0.27 in women from ischemic heart, and about 0.35 million in women or from stroke in men and women combined. Now, importantly, much of those that died of heart disease had a prior history, which is especially important for good secondary treatment. Now, to our surprise, the risks of death at this age were actually risen from 2000 to 2015, modestly in men and women. The risks for stroke had fallen, but only slowly. And this is a comparison of the age-standardized mortality rates at all ages, contrasting India from the million death study shown in the black to the US and UK, where you see declines in ischemic heart disease, both in men and women. The global burden of disease estimates, we think, are overestimated because they misclassify, or they take some classification codes for cardiac conditions and put them into cardiac, which we think is inappropriate. But nonetheless, you see this divergence between what's happened in India and the US and UK. For stroke, the key finding is stroke mortality rates, age standardized, are about 3 times higher in men and women than they are in the UK and the US, but they are showing a decline, and the GBD numbers seem to be not as much off. Now, stroke is interesting because it shows quite a varied pattern, that a third of the strokes occur in the northeast states, broadly the northeast of states, but also including Bihar and West Bengal and Orissa, Chhattisgarh, sorry, not Bihar. And these are a sixth of the national population, but they have a third of the strokes. So it looks like a very different pattern. Ischemic heart disease has well-described heavy concentrations, both in the north, that's up in Punjab and in Haryana, and also in the south. That's been well described. But the stroke distribution was less well known. And if one looks at the trends, surprisingly, there is an increase in rural areas in ischemic heart disease, but a flattened pattern in urban areas. And that may well be due to the factors that Dr. Anjana mentioned, that we think in particular under-treatment of ischemic heart disease through secondary prevention might be a key factor. For stroke, the puzzle is actually quite inexplicable. In high burden states, stroke mortality in rural and urban areas has been going up, particularly in rural areas. But in low burden states, it's been declining. Now, why? Well, the verbal autopsy cannot distinguish very clearly whether the high burden states are more characterized by hemorrhagic stroke, which would be the kind of patterns that you would see, for example, if you went to Burma and to China, you'd see much more of a hemorrhagic stroke pattern. But you can't distinguish that on verbal autopsy. We don't quite know what these reasons are for this divergence. Okay, let me turn quickly to cancer, which is some ongoing work working with Rajesh Dixit and Claudia Santucci and others. And this shows the age standardized mortality rates in middle age across roughly in forward projection to 2020. So roughly there's about 500,000 male and female cancer deaths at ages 30 to 69. Rates are higher in rural areas and slightly higher in richer states. And the leading causes are shown there. Basically, oral is the leading cause, colorectal, lung in men, stomach, and then you see the remaining causes. The overall trajectory has been favorable in that cancer mortality rates have been declining. That's overall neoplasms have come down. Oral cancer rates have mostly come down, though slightly less in the decline is slightly less in women. And then you can look at these other major causes. That's lip, oral, and pharynx combined. Stomach, as mentioned, has been declining. Colorectal has been declining. Liver, other digestives. Lung is a little hard to interpret because of that bump. We think it's actually not gone down and up. It's just about stable. Breast cancer mortality has also been modestly declining. Cervix has declined quite significantly, and these are some other less common conditions. So what are the key risk factors that are common? And I'll focus here on vascular disease, but clearly these are common also, particularly with smoking and perhaps diet, to cancers. So let me deal with these in somewhat of a reverse order. So well known is, of course, smoking, blood pressure, blood lipids, emerging lacto-vegetarian, low body mass. Temperature has been identified in the era of climate change, but importantly, cold temperature kills more than hot temperature. Particulate matter is often characterized as a risk factor for vascular disease, killing, by the global burden of disease estimates, the same number as smoking kills worldwide. But I'll show you evidence that suggests that probably just isn't true. So let's start with air pollution. So what we're able to do here is, because the Million Death Study is done in 8,000 small areas, randomly representative of the whole of the country, then you can take, and this is what Patrick Brown did, took 8,000 of those areas and then spatially mapped them to the very good NASA data on satellite exposures. This is what everyone uses for satellite exposures in the global burden of disease work. And you see, obviously, the highest concentrations are up abutting the Himalayas, and that's a combination of not being able to have the air pollution dissipate over the Himalayas, but also because of the crop burning and particular patterns in the north. So this is well described, and that's why Delhi can be quite unpleasant at parts of times of the year. So the question is, that's well known. The exposure levels to PM2.5 have been going up, such that the whole of India is well above what's considered the WHO safe level of below 10 micrograms per beater. But is it harmful? So we were looking, and by linking it to mortality. And when you do this carefully, and this has to be done carefully because you're looking at ecologic associations with a fair amount of potential confounding. So we tested a few models, and we were looking at heart attack, strokes, and respiratory disease specifically. There wasn't much association with cancer. So for heart attack, you see that if the basic model showed that there was a modest 2% excess, but if you then took into account the fact that heart attacks are also clustered where air pollution is clustered, then there was no association. For stroke, it was a bit of a paradox. It was actually not a risk factor. It was, if anything, protective. But then when you adjusted for the spatial distribution, there was a modest excess of 9% and 7% in the other approach that we did. We think this is simply a statistical phenomenon. It's not suggesting that stroke is actually in great excess, as I'll show you. And how do we look at that? Well, you look at dose-response relationships. So what we've got here is, in the solid lines, in the gray and in the orange, or the dark yellow, are the dose-response relationships in our study, and in the pure study, which is the gray line, of higher levels of particulate matter in relation to the risks of heart attack. And you see that's actually flat. It's the same with respiratory mortality. In the dotted are the global burden of disease models. And those are simply model-based. They have some empiric evidence from inappropriately analyzed studies in China about the relationship, but mostly these are model-derived relationships. Now, for stroke, it's a bit more complex. You see there is a slightly upward dose-response relationship, and the upper extreme of our confidence intervals, which is shown in the shaded, is broadly consistent with at least some of the GBD estimates. But then I didn't show respiratory mortality, but it would look like the heart attack. So in contrast to what is seen in the models, the relationship within India from direct data shows actually no clear excess mortality. Perhaps there's a little bit with stroke, but it suggests the estimates for how many deaths PM 2.5 causes in India are quite uncertain. Okay, what about climate change? Well, the key message is cold kills more than heat. And so this is work that Hannah Fu did, where you can do the same. You've got those 8,000 areas, and you use a method where you're using each area on a hot day as the case, and each area as a control day on a cold day. And then you can use this method, case crossover method, to measure the effects of temperature. And the key finding is you see that pattern of mortality, the blue for stroke, blue in colder temperatures below the kind of ideal or the lowest level, and the red is for hotter temperatures. And for both stroke and heart attacks, more deaths occur in colder than in hotter settings. And this is well recognized globally, that cold actually causes more deaths from stroke, ischemic heart disease, respiratory. Now, this is not to say that you shouldn't take climate change seriously for its health effects, but we have to be careful that the climate change effects, at least on cardiovascular mortality and respiratory mortality, may not be what we think that they might be. Okay, let me turn to vegetarians, which is a very unique situation, this study in India, and because vegetarians in India will tend to be lifelong lacto-vegetarians, meaning they'll consume milk and dairy products, but no eggs. So these are generally lacto-vegetarians. These are not. So in the Million Death Study, we have a question we asked, was the dead person a vegetarian? And we asked, are you a vegetarian with that definition? And then this is the distribution. And what you'll see is that vegetarianism is concentrated in the West, being lifelong vegetarian. On the coastal areas, you have people consuming particularly fish, but also meat. And so what we're able to do is, since we've got 8,000 areas, we're able to do 8,000 individual case control studies as to what is the relationship of vegetarian diet with cardiac mortality. And each unit is its control, so you're taking into account any differences in that unit and broadly in social economic status, or where they buy food, or even things like exposure to ambient air pollution. And the surprise, well, maybe it's not so much of a surprise, because I think Dr. Tara and Dr. Anjana mentioned this, is that for cardiac mortality, in fact, being a lifelong lacto-vegetarian was associated with a modest increased risk of cardiac mortality. And it was about a 10% increase in men, 16% in women, but notably higher in wives. And this is excluding drinkers and smokers. So it's not confounded by social class, because we've stratified for that in the analysis. But the main explanation for this, I think, as we've heard, is who eats last in a typical rural house. It'll be the wives. And what does this point to? Well, it's not the case that the difference between lacto-vegetarian and non-lacto-vegetarian is large quantities of meat. It's very little differences, but probably it reflects the type of diet and relative lack of access to proteins. If you think about who eats last and what's left over, it tend to be probably the least nutritious, at least in terms of the highest carb content and lowest protein content. So we think this is broadly consistent with the stories you've just heard. Okay, so tobacco. Well, when some years when Dr. Tedros tweeted when the air pollution results came out, he said air pollution is the new tobacco, warns the WHO had. I tweeted back to Dr. Tedros, sorry Dr. Tedros, tobacco is the new tobacco. He didn't reply, but I think I wanted to make the point. In all populations, including in India, among the current 20-year-olds, 25-year-olds that are smoking, the proportion that are killed if they continue to smoke is far in excess of almost any other exposures that you can think of. So this is the Canadian example. If you think of 1,000 20-year-olds, 250 are going to be killed by smoking unless they quit. How many will die in motor vehicle accidents? That's related to alcohol. How many will die in homicide and suicides? How many will die from particulate matter or others? Far, far less. So we have to remember the scale of tobacco hazards. And what has emerged only recently is, well, this in fact emerged on the 100th birth centenary of Richard Dahl's in Oxford, which was in 2012. We met to honor the 100th birth centenary, and a few studies from around the world were documenting the contemporary hazards of smoking. And for the first time, they got first evidence in women as well as in men. And the key is that now we were able to study women that smoke seriously like men, and we're able to there look at the hazards. So the top two are the results from Richard Dahl's last study from the British doctors, and Valerie Barrell's Million Women study, both showing that a typical smoker loses about a decade of life. The middle are the US men and women, which I'll show you in a second, is from the National Health Interview Study. These are Japanese atomic bomb survivors. And then these are Indian men in a retrospective study. You see this consistency about a full decade of life loss. That's the 21st century hazard of smoking. And this is how Brian Williams from NBC summarized our study from the US. Oops. Well, that 22 seconds summarizes my entire science career. So now the hazards of smoking in India have also only been reasonably documented retrospectively through the New England, in the New England Journal paper that looked at the million death study results. And the key finding is that the men who smoke cigarettes are now losing a decade of life lost. Men who smoke bidis, which has less tobacco than the cigarette, lose 6 years. The few women who smoke bidis are losing 8 years of life. Now, what has happened in India, as you know, the smoking prevalence has come down, particularly with bidis, but cigarettes have displaced bidis in relative consumption. They've both come down, but bidis faster than cigarettes. But despite the decrease in prevalence, the smoker, non-smoker mortality risks actually have become more extreme. So this is studying over a 10-year period for all medical causes, for cancers, respiratory disease, cardiovascular disease. And you'll see particularly they're becoming more extreme over time. And if you're the tobacco industry in India, your goal is to say, well, we want the bidi smoker to switch to cigarettes. And they've been remarkably successful recently by, for example, at this hotel, it used to be that all hotels were completely non-smoking, and now they've managed to have smoking floors that the tobacco industry has been able to influence. And the strategy is very much, they know they're not recruiting a lot of new smokers, but they want to switch the bidi smokers to smoking cigarettes. And if that happens, and they want them to smoke in serious amounts, then what you get is the heavy cigarette smokers, 10 plus a day, have the most extreme risks, but even heavy bidi smokers have more extreme risks. But because the hazards of smoking are so large, the benefits of quitting are ridiculously big and ridiculously quick. So as mentioned in the video, quitting by 40 gives you back on average 9 over the 10 years of lost life. But even quitting by 50 gives back 6 years of lost life. And this is important. There's many smokers that think, oh, it's too late. I started as a child or as an adolescent and I can't quit. There's no benefit. In fact, what we've shown in an updated analysis in high-income countries, because you can't study smoking yet seriously in India, but in high-income countries, of the benefit that occurs long-term, which is close to being never smoker death rates if you're a prolonged ex-smoker, that half of that benefit occurs very quickly. Within 3 years, you get back about half of the eventual benefit that you would from cessation. Now, a simple way to look at cessation is exactly like this. You just ask males, how many of you are smokers? How many of you are ex-smokers? And in populations where there's more ex-smokers than current smokers, you're doing tobacco control right. So in the dark red are the places where tobacco control has been done reasonably well. And there are some surprises. Brazil wouldn't be in that color scheme up until the last decade, but it took taxes seriously and was able to raise cessation rates. Ignore Africa because there's some survey problems there, but focus on the yellow. And the yellow is where cessation is not occurring. Cessation often occurs because of disease, not to avoid. You know, that adage that, oh, cancer cured my smoking, is very much the phenomenon in India, China, Russia, Indonesia, Philippines, and large parts of Asia. So this is very much where the global battle front lies in terms of getting that group of smokers to quit. What's essential for smoking cessation? Well, higher taxes. And this is where, unfortunately, India has really fallen behind by being an early leader under Dr. Ramadas and others in raising taxes. Taxes here have really been unchanged in 2017, but of course, incomes have gone up, and so they're relatively more affordable. Cigarettes are well short of the WHO target price, and importantly, the tax structure means that the tobacco industry is actually pocketing much of the revenue. They blame the government, but they actually increase tax to maximize their profit. So what's needed is something that Govinda Rao and we wrote some years ago, which is a big, like 100% larger specific excise tax, starting on cigarettes. And then you want them to be done so you prevent downward substitution to the cheap, shorter cigarettes. That's the industry strategy. If you raise the tax, and they go every year to the Ministry of Finance and they say, we know we're the bad guys, whack us a bit this year with GST, we'll complain about it. And then they go and they very cleverly decide that they're going to sell more of the shorter, cheaper cigarettes. That pulls the bidi smoker away from the bidi smoking to the cigarettes, and then they switch them up to the ones that they can make more profits because they've got them hooked with customized design nicotine for them. So the industry is absolutely ruthless, but incredibly transparent. And I've just always been surprised why Ministry of Finance officials just don't do the opposite of what the industry does. Okay, well, there's many examples of taxes work. South Africa and France are an example. And a simple way to remember this is tripling the cigarette price will have consumption and also give you a nice major increase in tax revenue. Okay, let me turn to to what I think is needed in terms of 21st century epidemiology in India. And a lot can be drawn from the lessons from the UK Biobank, and Rory Collins has a nice analysis saying, what makes the UK Biobank so special? Well, it's these 4 features. It's large, it's deep, it's got very deep phenotypic and genotypic information. It's sufficiently long so that you can study important health outcomes, and it's openly accessible. It was set up so that UK Biobank is judged as a library. How many books are borrowed, not how many papers are written. And by that measure, it's been a spectacular success. There are other biobanks, of course. The most relevant one for this country would be the Chinese Kadoorie Biobank, but there are other ones. And Rajesh Dixit at Tata Memorial Center, working with Dr. Pramesh and others, has started a study in one district, Solapur, which has got 1.2 lakh adults recruited, and the idea is to end up replicating that in Goa and a few other places. The right scale to think about for India would be, given the enormous diversity, would be to have that kind of setup in several settings, particularly in the Northeast, which is unique, particularly in a place like Odisha, or particularly in the tribal areas, but also in the South, because India is so heterogeneous that you can imagine a few of these places. And I think the ideal sample size would be to have 10 of these, so it'd be about 1 million people enrolled. Okay, I would like to emphasize open access, because I think it's very much is the future. So the Million Death Study now, and all the results are openly available through open mortality. So everything that I've shown you can actually get and make available to students. We can make it all available for further analysis. So let me conclude again. Remarkable variations in India that we still don't understand. We've got important actionable risk factors, particularly tobacco smoking, and that do need attention, but we do need a lot more research to sort out some of the uncertainties, particularly on low body mass index, but also blood-based epidemiology. Thank you very much.
We'll do the questions after. Okay. So, yes, Dr. Professor Muralidharan from IIT Madras.
So tell me which one is this for? This is the pointer?
Yes, this is the pointer.
Okay. Right. Thank you. I should stand here. Speak, of course. Picture, okay. Right. Good afternoon. I would like to begin by first thanking the organizers, both INSA and the Royal Society, for inviting me to be here to share our experience from the DHR point of view, from the Department of Health and Health Research and ICMR point of view. I have been a member of the TAC, Technical Advisory Committee of the Health Technology Assessment Initiative of the Government of India, and since its inception in 2017. So let me begin by asking a a very general question, posing a general question, a question that many of us, almost all of us, since yesterday have posed explicitly or otherwise a question that on an average government spends much less than what is required for health on a per capita basis, and on top of it a lot of that is being spent perhaps is not could have been spent better, and a lot of it is perhaps unnecessary or wasted. On top of it, therefore, the following question makes even more sense. In a situation like that, as I described, especially when a new device or a treatment or a diagnostic test or a treatment or prevention strategies is proposed, the question, is it worth spending on something new, becomes even more important, because we are already having very little money for healthcare, and we are demanding for more and more allocation for healthcare. Therefore, question is, how has the government responded to address this question? And I will narrate very briefly the story of health technology initiative of the government of India, particularly the Department of Health Research, since its inception. I give an overview, I give a brief analysis of a sample of studies carried out so far. I will give a few illustrative examples of how such studies were adopted, who adopted it as part of their regular programmatic interventions, and then some questions on where we are, what we should do to make this process more effective. That is the outline. So, this is my preliminary prelude. As I mentioned, a lot of money that is spent is perhaps could be spent even better. So, primary aims are, if you read the preamble or objectives of HDAN, is to maximize health for the amount of money that we spend, reduce financial burden on people, and also address the inequity or inequality that we discussed in terms of health status, health spending, and so on. Story, this is a timeline of how we progressed since 2017 when it was established. In fact, in national health policy there is a direct reference about the importance of HTA studies that will help shape policies in India. So, I want to first highlight 3 or 4 things on the bottom of this timeline. So, when you know that when you want to do a cost effectiveness study, so there is a denominator, there is a numerator. Okay, so we began with no numbers on both denominator and the numerator. We had no data on cost of interventions. We have no data on the impact of that intervention in terms of health outcomes. So, the first thing, therefore, while a series of studies were introduced, they were all model based, even now largely borrowing projected estimates from other countries and contextualize it in the Indian context. But the first major step was to prepare a manual on principles to be followed while carrying out HTA. So, I will display the more details of those later on. And then we worked on parallelly developing measures of quality of life and costing, very massive all India level studies I will not be able to go into the details of it, but you will have references to read the original. I will give references as we go along. Then later on, we also developed, when I say we, I mean the whole team that undertook the study on behalf of DHR, on quality assessment checklist. We also developed what we called an economic evaluation reference case with specific reference to India. And right now there is a large study which is at this almost complete, is undergoing some reviews on fixing a threshold value for cost effectiveness ratios. And then what next after the study I will indicate at the end of the presentation. I want to also tell you as part of the milestones, the DHR developed an MSc in Health Economics course approved by the Government of India, UGC. Though not many universities have come out with the program, a 2-year or 3-year program, but it is there, and 1 or 2 places it is being offered. So broadly the ecosystem is this: you have the HTAN secretariat located in DHR, you have a board, medical technologists board, which finally approves and recommends to the Government of India for adoption. You have number of users. Right now all studies are demand driven, so it comes from various ministries and state governments. You have technical appraisal committees, which initially reviews and recommends for study of a given proposal for introducing a device or intervention. Then we have number of resource centers, close to about 30 of them established across India to carry out studies. This is an incomplete map, but just to give you a sense of how they are, the centers located all across India. So we have 8 resource hubs and about 20 resource centers. All of them have now an office with expertise to carry out studies recommended by the TAC, the Technical Advisory Committee, to test an intervention or a device, how cost effective they are compared to a comparator, in comparison to existing intervention. And together, this is about the process. In a sense, I have already indicated that the demand for introducing a device or a procedure, a proposal comes from an innovator or a state government, and it goes through a process, appraised by TSC, and then consultations with stakeholders, then there is a recommendation, it goes to the board. Before that, it is sort of evaluated by a resource center from among the 20 centers that we have already established. So far, since 2017, HTAN has undertaken 104 studies completed, and many are underway, 75 of them in progress, 308 publications we have, and about 50 interventions have been already adopted by various governments. And they are all listed in their website. You can go and see which of them. Some of them I will highlight. So in the first 5 years, there were 39 studies. The next 2 years, the last 2 years, almost more than double the number of studies initiated. So you can see the amount of effort being made so far. So what I am going to show in the next 5 minutes is to give you a quick review or analysis of the studies, 39 studies carried out in the first 5 years. A simple analysis of what they are and what they indicate. So out of the 39, we removed 6 of them because they either were very rapid HTA. We can't strictly classify them as HTA studies, and using other criteria. Eventually, we ended up with reviewing 33 studies. And these were the centers that carried out, all put together, 33 studies. So you have centers. The Secretariat itself carried out 4 studies, many of them from Chandigarh, NIRT, Chennai, from Trivandrum, Mumbai, and so on, all recognized as resource centers by HTA and DHR. I don't want to give any impression from this that diseases that have a high DALI per 100,000 population, which is ranked very high in terms of DALI, have 5 studies in terms of importance, number of studies undertaken in the DALI. We need to wait for another 5 more years to see whether the studies undertaken reflect the importance in terms of DALI burden. It gives us a general idea. So, the introduction of a technology you can classify in terms of the tests, the innovative tests, or a device, drug, vaccine, or a procedure, or in terms of program, or even systemic interventions. And you can also classify in terms of application. A device is in terms of prevention, screening, diagnosis, treatment or rehabilitation, and palliation. So, what we did, we combined both and looked at the 33 studies. So, if you look at the number of devices introduced, 4 of them related to treatment, 3 related to screening, 1 related to prevention, and 3 on diagnosis. Likewise, the 2 drugs that were studied, both of them were related to treatment. It's just a simple classification to get a sense of nature of work being done. All of them demand driven. So, it is not strategically planned to undertake. Okay. Then what we did, we used a checklist used by Drummond to evaluate the robustness of the studies, and also the Indian reference case, a set of 11 indicators that we used to evaluate the robustness and how they fare. So, the Drummond checklist is well known. There are 10 criteria to be tested, whether they have a clear question, whether alternatives are well defined, the effectiveness is established, whether you have listed all the costs and consequences, and the time frame, discount rate, whether you have carried out incremental analysis or not, whether you have accounted for uncertainty and the limitation. So, every proposal, every one of these 33 studies will be detailed analysis, see which of these, whether all of these have been addressed, and we give a score on a 10-point scale. Likewise, we took all the 11 criteria of the Indian reference case and then give scores from 0 to 4. So, if the study proposal 1 had the decision problem well defined and covered all the 4 sub criteria, burden of disease, available option, population intervention, comparator and outcomes, subgroups, we give 4 on 4.
Likewise for each of these, whether the study looked at equity issues, distributional weighting, and so on, and depending upon our own judgment, okay, we give a score of 4 or 0. And for each of these 33 studies, for Drummond, we give 1 on 10, and then with respect to Indian reference case, we give out of 11, and then we reduce it to 10 marks. And we do a comparison. I'll skip this. We did a comparison. So what is the average score according to IRC, Indian reference case, and Drummond, how they compare. And you can see systematically all of them except this have a score lower according to IRC compared to Drummond, okay? All of them on an average. So what it basically means is that IRC is more demanding in terms of, you know, criteria to be fulfilled, and if you follow that reasonably, that proposal is a robust one compared to Drummond. That's the. I'll come back to this again later on. So what I said is in this figure, out of 33 studies, 28 of them showed that the intervention proposed was cost effective, and 3 of them were not cost effective. Okay, it's a repetition of the previous figure. Now, next 5 minutes, I will take 3 or 4 examples to give you a specific conclusion of studies on intervention. Okay. Take the example of introduction of safety engineering syringes. Example of low cost portable ventilator. Then what is called TrueNAT screening for device for TB, and use of introduction of intraocular lenses for cataract surgery, and then one at systemic level looking at the entire health insurance scheme, coming out with a new package, how to rationalize the total expenditure budget. So the first one was undertaken by Chandigarh, a postgraduate institute of medical research. So what it's difficult to read. I have got the next slide that shows the main findings. So those of you interested can go back to the full policy note and the report. What it says is that reusable syringes will become cost effective at a unit price of 1.9. Likewise, the what is called sharp injury prevention syringes will be cost effective at a price less than 1.8. This is a study which actually was adopted by many states. As a result, RUP syringe was adopted. This is a study carried out by Kalam Institute for Health Technology in Andhra Pradesh. What they came out was this, that this new device is cost effective at 4,845 rupees per quality gained, while the standard of care is cost effective at 4,800 bucks per quality gain. The low cost portable ventilator reduced mortality by 40% compared to mechanical invasive ventilator, and it has been approved for purchase in 9 different states. I am giving only highlights in view of the time. The next is use of the TrueNAT screening device for TB. This was undertaken by not sure which, it was undertaken by DHR, no, Secretariat itself, yes. So, they came out with the findings that TrueNet as compared to Gen Expert is very cost effective in the Indian setting with an ISER value of 8,400, that is the incremental cost effective ratio. We will comment on that later as towards the end. Then TrueNet has been adopted as a screening device in Andhra Pradesh. Then introduction of intraocular lens for cataract surgery, which was also undertaken by the Secretariat. What they concluded was with this, that both phacoemulsification and manual small incision contract surgery showed comparable clinical efficacy in terms of visual acuity and complication. Phaco is cost effective over MSICS at the ISER rate of 3,862 rupees. Okay. And it was adopted by Uttarakhand and right. So, and there is the third bullet is important, that however, MSICS is most appropriate strategy in rural India where age related contract is prevalent among the poor and there is a lack of medical infrastructure. And finally, the example of health benefit package rationalization, the whole Secretariat which worked on package 1 was asked to relook at the package and see where all we can sort of rationalize the expenses. They came out with the package of 2.0 consisting of 866 shall I say in packages, procedures to be supported. So, if you look at the impact of HTA, it is useful to ask as a kind of review, but at least based on study so far, you can look at different levels. One is the number of studies undertaken, number of studies ongoing, publication we saw, but adoption by the government. So far, we have the complete list of 50 of them and who initiated the study, the demand for the study, and what were the results, and who are the states which adopted as part of their public system. These are all listed in the HTAN website. I showed only 5 of them in the example. Just a recap, as I said, this manual that you see on the left hand side is the first publication that gives the guidelines to be adopted while carrying out cost effectiveness studies. Then we also developed the health related quality of life set values for number of interventions, that was in 2020. Then costing exercise, a major one with samples of intervention and different settings across India. And then there is a quality check guidelines. And right now the second edition of the manual or the guidelines to be used for fixing threshold value for ISER is underway. Right now those who are doing the study, cost effectiveness study, the threshold value they are using is about 1.5% of average GDP or 1%. So, broadly the manual comes out with that conclusion, but we are still having a discussion on that. So, next 2 minutes I will close with a summary. What we need now, and the DHR is already working, or rather HTA and Secretariat is working already to prepare an explicit framework for selection of intervention, what kind of intervention that could be evaluated and supported. We are now more driven by demand, okay? But supposing we get 10 proposals. Which of them to be chosen first itself is a point for discussion. We need to explicitly take more preventive interventions. This adherence to Indian reference case and HTA manual helps improving quality of economic evaluation. Certainly, we find a recent study by Shankar Prinja and his team looking at all the studies done so far through and evaluating the robustness of the studies of the proposals. They come out with the suggestion that we need to improve the robustness of evaluation studies itself. We also need to undertake more studies on effectiveness and operational feasibility. We haven't been able to address explicitly the equity issues, the distributional part of it. We are able to say yes, it is cost effective or not, or how cost effective it is compared to the threshold, but the distributional aspect, who benefits to what extent across the states, is still a long way in our journey. We need a very specific cost effectiveness threshold for India. As I said, we are working on it. But equally important, therefore, is to do a affordability analysis. Whether we have the budget, what is called budget impact threshold. So we need a cost effectiveness threshold, and also we need a budget impact threshold, which I suppose will be the next step. We have a most recent paper yet to be out in December, I think, but we've got the e-copy of that, which talks about budget impact threshold, and they provide a framework for that. And I will conclude by saying that we need to do HTA on interventions that were already approved some years ago, but we need to redo again, periodically revisit proposals on technologies that we have already approved. I stop here. I thank my colleagues and Dr. Kavita Rajshekhar, who is heading the DHR team from Government of India. Some of these that I presented will be published in this journal sometime a month from now on. Thank you very much. Okay, so this is just if you wish to see the formula, nothing beyond that. Okay, this is a famous bookshelf representation of Collier on showing how if you push the budget limit to the right, you can accommodate more intervention. But that's the point that I made in the last bullet. Where are we? So, thank you.
Thank you very much. I was curious as to your thresholds, the disease control priorities, and Drummond and others have usually said 3 times per capita GDP is considered a good bet. I'm curious as to what the thinking is in India.
So, as I said, we are right now finishing the second draft of the report. The current draft indicates that 1.5 could be 1.5 of the times of the average GDP could be the threshold. But as I said, budget impact implication will have to be also linked with that. But it is not 3 times, it is not 1, it is about, according to our work, the technical report, it's about 1.5 they are suggesting. But we have to have a series of consultations on that. Yeah, it is slow. Some people, I mean,
Don't you risk undervaluing the, I mean, you know well from the work Stefan Verge and others have done that even small changes in mortality based on any VSL estimates, have an enormous return. Families will pay extraordinary amounts to have even a small gain in survival. And it'd be a shame to have the policymakers get off saying, oh, Indian lives, somehow you can get away with cheaper.
My own impression is that it should be higher. How much more higher is a different thing, but 1.5, many people were not hesitant, but the study team has gone about in a particular manner. We are under review, it is under review. But if I want to say, my gut feeling, if at all, is certainly I'll be along with you. Yeah, I'm inclined to be along 3%, 3x.
So, if I can be a little bit controversial here. So, as doctors, we all want to save lives, but increasingly we live in a world where the economists hold the cards. And again, I had a very, we talked about this yesterday, I had a very sort of controversial discussion with an economist who also made a comment about dying is cheap. So for a society, if you let someone die at 75 versus 77, once they're gone, they're gone. But if they have a non-fatal event and they remain alive with disability, that's worse for the country. How do we square that? I mean, I feel it sits uncomfortably with us, but there's always this constant sort of battle, and I feel that the economists are winning at the moment, because even arguments for prevention are made on economic benefits as opposed to kind of life benefits. And we heard also earlier about healthy aging and pushing disease back. So, anyway, just interested in your thoughts, either one of you, I guess. Who wants to?
Yeah, so both things have to be done. If you actually, Collier has repeatedly emphasized, Anthony Collier from York, that in this exercise, it's not a toolkit where you give a formula, it gives you the answer. There's a lot of negotiation and consultations. The cost effectiveness study is complete only after this, following the manual or whatever. There's a lot of negotiation or consultation, because the fairness part of it can be accommodated only through genuine consultation. What a government can afford to pay. Very contextual, at the same time, as I mentioned, and in the last Lancet paper, forthcoming reference, the budget impact analysis about the affordability. And that's a tough question. So we are far from that, far from in the sense that we don't have the numbers to argue a case. As I said, we began, the STA Secretariat began with nothing about numerator or denominator. So we have now numerator and some denominator. Now we are looking at the threshold for ISER value, which is going to result in a lot of consultations. There we look at the kit and also reallocation of resources and increasing the budget for health. Then comes the budget affordability. So parallelly work is going on, how much fiscal space do we have to allocate, to reallocate resources from other sectors to this sector, as well as budget's fiscal space for raising more revenue that could be allocated for health. So now there's a conscious effort to look at that instead of being driven historically. So I think you should not worry about economists bulldozing the show. A good doctor is a good economist. as a person, intensivist decides when to say no, he's a good economist. So he decides when it is worth to stop funding. So likewise, I think a good economist should understand also the budget implications. So you have some response?
I agree with that. I mean, I'll be careful what I say about economists because I'm married to one, but good economists will not underestimate the willingness for people to pay extraordinary amounts to live a little bit. That's been well established in literature. And I think for personal experience, we all know, I mean, even you take something like, take a case of bone marrow transplant in India. If it's not covered under any insurance schemes, or there's most, but even middle class families will borrow into their future to have a 50% survival rate, right? So the willingness of people to pay for their health is something that I think we need to keep reminding economists. More formal economics work, I mean, Bill Nordhaus won a Nobel Prize for his work on the basically long-term value of addressing climate change, for example, but people like Kevin Murphy and Topol have looked at what's been the economic value of longevity in the US. And their number was featured in The Economist. They said that just the gains from heart disease in terms of prolonged survival equals all of the US income wealth over the last 50 years. And then they further, premature, just willingness to pay at a very modest, 3 times the national income. And then what importantly they said is you trace that back, almost all of that gain has been from public funding through NIH and through research. So I think making the case that you need to change the cost trajectory needs research. But I've never, any economist who says euthanasia is good policy doesn't deserve to be in any decision-making authority.
I just want to respond, Riaz, to something that you mentioned. And I'll be the first person to say that the Indian government needs to spend at least 4 times what it's doing right now on health. We just spend 1.3% of our GDP on health. It should be closer to 6% is my feeling. But at the same time, and I'm speaking both as a doctor and as an administrator here, letting it completely to the doctors is not a great idea. It's happened in the US. They spend 19% of their GDP on health, and their health outcomes are not necessarily even as good as some of the East Asian countries, say for example Thailand. So I think there needs to be a balance between what we consider. And I'll give you a concrete example of how health economics has actually helped countries. There was in cancer a new drug called aflibercept, which came in at half the cost of a similarly active drug called bevacizumab. And bevacizumab was costed at $11,000 a month, and aflibercept came in at $5,500. The then CEO of Memorial Sloan Kettering said, I'm cutting off bevacizumab from the hospital formulary because aflibercept has an equivalent outcome at half the cost. 1 week later, the company dropped the cost of bevacizumab to $5,000. So I think there are plenty of examples of how a good health technology assessment has actually helped negotiate costs and actually overall improve. Because I don't think any country today can take a stance that their healthcare budget is a bottomless pit. We need to use it wisely and rationally, and I certainly think a good HTA helps with that.
Can I just add, thank you, great comments. I just wanted to add that we do have some experience in the UK of like standardizing formularies and standardizing our approach, often based on health economics and based on population data. The thing that's relevant to both our themes is the way in which if AI then changes our way of making decisions at the individual doctor level and how that, and healthcare provider level, and how that will percolate out throughout the system, because we're both physicians practicing in the same hospital, in fact, and there is a range, there's a distribution around what would be considered a legitimate clinical decision. It's not exactly how you and I might make not exactly the same decision for the same case, but in our standard practice, there's a distribution of risk tolerance, right? And therefore money spent or not, depending on whether or not you want another MRI scan or you're just happy to discharge based on the information you have. And there's it's kind of set at the moment according to how we standardize practice. If AI makes us more conservative and patients' expectations more conservative, then we're going to drift into this expectation where inevitably we don't take risks, we don't understand risks in the same way because it's so AI supported. Whether or not that's a good thing or whether or not, I don't know, the window for that to really understand that is shrinking. But that's a big concern, that we won't be able to constrain our costs anymore because using clinical and epidemiological data, because a machine is going to tell us what the risks apparently are. Yeah, I think AI will drive up patient expectation and doctor expectation in defense in a way that is unanticipated, but is likely to be more conservative than is now the case now, i.e. more expensive, but not necessarily higher quality.
I have a more basic question. If I want a health technology assessment done, how do I go about it?
Very simple. So go to the health technology HTAN website. Just Google HTAN DHR. So you'll get that. And then there is a guideline. If you want to submit a new proposal, click here. It goes there. So you submit. And there is a secretariat which will review quickly. And they will get back to you about, give their feedback on what next step. So there are things to be fulfilled if you want DHR to undertake a full-fledged study through a regional center. One of them will be to invite you to present to the TAC, and there will be feedback. You go and revise. Secretariat will help in revising. Then you come and present the revised one. You say okay, and the budget is released from Secretariat. The regional center will carry out. Come back and present the results. There's a review process, like the journal kind of thing. There's a reviewer, they will comment. And mostly it goes through one more review, not a restudy. And then next step is to the board, and board recommends. And then the respective state will have to spend money to adopt it, because the demand came from that. So HTAN doesn't give budget for implementing. Their role stops there.
So it has to go from a government agency?
Not necessarily. We have had private institutions. They came out with point of care, devices. So it goes through.
Who pays for the assessment?
Well, if it is from government pays. If it is some private agent, they will have to pay for the study. There will be some support. I mean, for example, regional centers which carry out all the resources, the expertise, that's not charged. But it requires some budget to carry out the fieldwork observation. So there's some negotiation will be there with the private party. But you get a lot of expertise. Yeah.
Do you share these with other countries that have similar criteria, or are they just used in India?
Sorry, we have had 2 international workshops where these studies, some of them were presented. And as part of the workshop, we also had capacity building parallel sessions after the conference or before the conferences. We have had many within India workshops for building capacity. So we bring some outside foreign, both from UK and Thailand in particular. And some of them are presented, and already we have several papers published. That's I hope that's what you asked. Yeah.
I was just thinking about the very different settings. For example, if I imagine the calculations would be extremely different if you'd go about it in the US versus the UK because the healthcare systems are so different. So I wondered if there were other countries that had systems more similar, insurance-based, more similar to
Yes. In fact,
India.
if you look at the literature we have used as part of while developing manual, so there are at least one major chapter on comparative comparison with other states, other countries, what they follow, both Western Europe and other wherever HTA studies are undertaken. There's a comparison in the manual itself. And we have had experts from NICE and Thailand in particular and UK to give their comments on our approach.
Dr. Jha. So in the million death study, so this morning we were talking of death from diabetes and coronary vascular disease amongst people who are socially, economically lower placed. So did the million death study document what was happening amongst different economic strata?
Unfortunately, no. After 2003, the education was recorded on the death certificates 2001, 2, 3. After that, I'm kicking myself on this because there was a saying, oh, don't worry, we have all that other information and other data, we'll just link it. The link it never worked. So what's only available is districts, and so you can do area level, broadly area level wealth, or you can look broadly at tribal districts and so forth. So the deaths are geocoded, which enables some novel ways of looking at socioeconomic status. You can use satellite nighttime data, for example, to establish low and rich areas. But the limitation there is because it's an area. It could be Mr. Ambani's tower there, surrounded by the village, by the slums around, and that's the limitation.
So the plan is now there's time for a networking break, and then there's going to be a closing session that starts at 4:10. It will be combined with the other theme. I'm not sure which room it will be in, but I'm sure they will shuffle us into the correct one as required. If there are points that you would like made, because within 5 minutes, the two of us are supposed to be able to summarize 2 days. So are there key points you would like us to make? Raise them now. Otherwise, I think we'll try and give a sense of the range of things that we discussed and the complementarities we saw.
Open data. Open data.
Okay.
I wish ICMR would adopt the policy that NIH has.